well. It is going to be a 2-hour master class between 7:30 and 9:30 p.m. next Friday. And then every last Sunday, as I told you, the TNOA Connect series, wherein I'm connecting all the major institutes. As you know, the major institutes are all in Tamil Nadu, like Shankar Nethralaya, Aravind, RIO, GOH, the Agarwal, the Eye Foundation, and so many other institutes are there, wherein we connect everybody together. So they connect, consolidate, and communicate, and that is the theme for this Connect series. And this particular webinar is being done by the Shankar Nethralaya. I'm very thankful to the coordinator, Jayantan, who is a member of the management committee of the TNOA, and also to Kavita, who's been taking care from the side of Shankar Nethralaya, coordinating from that. So with these few words, I would like to request my mentor, Dr. T.S. Surendran, without whom we are all not here today. And no, he's been a friend, philosopher, guide for all of us, all the alumni of Shankar Nethralaya. When we are students, he was even now he's the most popular teacher, I would say. Dr. TSS to give a few words, and then followed by Dr. Meenakshi, who is the head of the Pediatric Ophthalmology department as well.
Actually, as per the program, I think I'm supposed to introduce Frank Martin, who is giving the keynote address first off.
No problem, sir.
Followed by my talk. Then I think Kavita will follow it up. So I think எல்லாருக்கும் புத்தாண்டு 4 days தான் மஜா தான் தமிழ்நாடு. I think all the best, Mohan, for giving this opportunity, and I thank my team, especially Dr. Kavita, for formulating the program in just less than 48 hours. So I have great pleasure in, and I must congratulate, I think, Jayantan and also all your associates who have helped with this webinar.
Yes, sir. Thank you,
So
sir.
with these few words, I think Professor Martin is there, no?
Yes, sir.
So
Sir,
I introduce.
We'll come back to Professor Martin a little later, sir. I want Dr. Meenakshi to say give some opening remarks, and then Dr. Ramakrishnan is also logged in, our President Director of TNOA. He also would like to say a few words, and then we introduce Professor Frank Martin.
Okay.
Yes, sir. Meenakshi.
Thank you, Dr. Mohan. And a good morning, a very good morning to all the esteemed panelists and esteemed speakers. And a very, very happy morning and happy day to Dr. Frank Martin, who is a good friend and a long-time associate of Shankar Nethralaya. Thank you so much for joining us on this Sunday, despite all your other commitments. And as always, we eagerly wait for your keynote. Now, pediatric ophthalmology has grown by leaps and bounds in the last couple of decades, especially that I have been associated with Shankar Nethralaya. It is one of the most popular subspecialties now amongst fellows. And as you can see, the future is going to be in the hands of the pediatric ophthalmologists with the myopia boom that is coming, with exciting treatments for myopia, exciting treatments for amblyopia, things for which we thought nothing was possible. So this is an exciting era to be a pediatric ophthalmologist. And I am so happy that the president of TNOA, Dr. Mohan Rajan, has given us an opportunity to share with you our knowledge. He has reckoned very, very clearly that this is an important specialty and this needs to be showcased. The information needs to be shared with everybody, with not just pediatric ophthalmologists, but also the general ophthalmologists who are going to be the force of Tamil Nadu Ophthalmic Association. They are the pillars of Tamil Nadu Ophthalmic Association. So we have tried to put up together a program, and Dr. Kavita, Dr. Jayantan have done a wonderful, wonderful program on this lovely Sunday morning for that very reason, to make sure the topics are important for all the general ophthalmologists that make the TNOA and who are doing wonderful practice in our state. Our state, Tamil Nadu, has one of the highest standards of ophthalmic practice, has some of the best institutions in India. I'm just so proud to be a part of TNOA and a part of this wonderful program. Thank you and all the very best.
Thank you, Meenakshi, for your nice words. I think Tamil Nadu is a mecca of, I would say, the ophthalmic teaching, and the standards are very high. And to keep this standard high, this TNOA, what we have done this time is this thing called Publish and Prosper, wherein we're encouraging peer-reviewed publications. The first author gets a cash prize of 2,000 rupees and a medal and a citation. And we've been doing it. We have given it to already about 35 people. And also the ophthalmic photography competition for the World Sight Day. We also had a national quiz. Yesterday, we had a very important webinar on the cracker injuries along with the APOTS. And we are having multivarious activities as far as TNOA is concerned, covering the entire spectrum of ophthalmic care, and even the non-ophthalmic activities like the Clinical Establishment Act, the insurance-related work, and all these things, the NABH, the postgraduate protocols, and all these things are also we are covering in these webinars. If Ramakrishnan is there, President-elect, I would of Tamil Nadu Ophthalmic, I request him to say a few words. Ramakrishnan, sir?
Yes. Respected President, Dr. Mohan Rao, and my dear Sir, Dr. Surendran, and Dr. Meenakshi, and Jayantan, and dear faculty members. Good evening to all. As Mohan Rajan pointed out, every month, starting from the last month, we have a variety of academic activities by Dr. Mohan Rajan and his team, and of course the TNOA as a whole, covering all the topics. Even last month we had a wonderful session, and this month also this is the first webinar as the pediatric update on pediatric ophthalmology. I'm really happy that because every month we have some important specialty like glaucoma, retina, cornea, something like that. In that way, this month pediatric ophthalmology is mainly the update on pediatric ophthalmology. I'm happy that all the speakers are very well versed with the field of pediatric ophthalmology, especially mostly from Shankar Nethralaya, and of course the guest speaker Martin is also there. And the topics are not only useful for the practicing ophthalmologists, and also it is very much useful for the fellows as well as the postgraduates, because nowadays, especially in this COVID era, the teaching is not like what it was there earlier. So this type of webinar is very much useful for the postgraduates also. I hope many of the postgraduates are very much interested in listening to this webinar, and I feel that definitely it will be useful. And of course, I am very much thankful to all the faculty members of this pediatric ophthalmology update, because I saw the topics. These are wonderful topics selected and arranged by Dr. Kavita and Jayantan. I have to congratulate them. And as a whole, I am expecting a wonderful academic feat today. Thank you very much.
Thank you, sir. Welcome, Professor Frank Martin. Thank you very much for joining us, sir. Over to Kavita and Jayantan to take over the entire webinar.
Thank you, sir. Thank you, sir. With this introduction, we shall go ahead and start our webinar, which everyone is eagerly waiting for. I want Dr. T.S. Surendran to quickly introduce Dr. Frank Martin, who will be delivering the keynote, which is the lecture of the day.
Good morning to everybody. I think Dr. Frank Martin needs no introduction. He has already come to Chennai to give the Nagamani Dharmapuri oration. So he happens to be the head of the Department of Ophthalmology and at Sydney Eye Hospital and Royal Darwin Hospital. He's also the clinical professor in the Department of Pediatric Ophthalmology at the University of Sydney. And he's also president of Asia Pacific Society of Pediatric Ophthalmology and Strabismus, wherein I am the scientific secretary, and this association has been going on for 10 years. And I must thank Frank Martin and Dennis Lamb to have started this. And I think last 15 years back or so, 2000, I met Frank Martin at Hong Kong Chinese University. And both of us, along with other faculty, we conducted a workshop in pediatric ophthalmology. I think the association dates back to 21 years. He is also...
Some echoes there, sir.
Pardon?
Some sound echoes there. Sai, can you just check?
Because I don't have any other gadgets.
Yes, sir.
So he has given momentous lectures, and as I mentioned, I think ours was one of them, and he's totally, I think, involved in pediatric conference. He'll be there. With these few words, I welcome address.
So I invite Dr. Frank Martin, sir, to please deliver his keynote lecture. So please unmute yourself and you can share your slides.
Well, thank you very much, Dr. Kavitha and Dr. Surendran, for inviting me to participate in the Tamil Nadu Ophthalmic Association workshop on pediatric ophthalmology and strabismus. Pediatric ophthalmology is a very special part of medicine because as pediatric ophthalmologists, when we see children, we have to make a diagnosis without the child being able to often give us the history. We're relying on others. Today, I'm going to talk about traps for young and old players in pediatric strabismus. I have no conflicts or financial interests to declare. When we see a child with strabismus, it's no different to any other part of medicine. We take a history. But the history often comes from the parents because the young children, they can't tell us what's wrong. We're relying on the parent or carer to give us the history. Then we examine the child and we formulate a diagnosis. Sometimes we go ahead and organise investigations, and then we manage the patient. Well, it's very easy to fall into traps when we're dealing with strabismus. And why do we fall into a trap? First of all, we don't listen to the history. Secondly, we ignore the concerns of the child and the parents. And thirdly, we don't examine the child carefully. The result of this is that we end up with an incorrect diagnosis and an incorrect management. I'm going to talk about 3 patients that I've seen over the last 12 months, which bring this message home to us. And I'll share these 3 patients with you. First of all, Julie, a little 6-month-old girl. Her mother came to me with a history that the family had noticed that Julie was tilting her head to the left since her birth. They took Julie to their pediatrician, who confirmed this. And at the time when they were seeing the pediatrician, the older sister, who's aged 12, she volunteered to the pediatrician that she's noticed that Julie's right eye sometimes drifts upwards. The pediatrician, torticollis, this is must be a problem with the neck, so off to the physiotherapist. The physiotherapist was seeing Julie every week, and Julie was not improving. Julie's mother kept raising with the physiotherapist, like, I think there's something else is wrong. She contacted the pediatrician, but her concerns were ignored. So she decided to try and do her own investigations, and she went to Google. She Googled torticollis and found that the eye problems can cause torticollis. So she self-referred Julie to see me. Well, here's Julie with a very obvious head tilt to the left. And what would a pediatric ophthalmologist, strabismologist do? The first test we do, we see what happens when you straighten the head. And when you straighten Julie's head, what happens? The right eye goes up. So Julie obviously has a problem with her eye, and this is due to a fourth nerve palsy. So Julie, for 4 months of her life, was receiving unnecessary physiotherapy when the diagnosis could have been reached very simply, and Julie's problem managed with a right inferior oblique myectomy. Let's look at our second patient. Our second patient is Rosie. Rosie's 4.5 years of age. She was brought to see me for a second opinion. Parents gave a history. She's had a right ptosis from an early age. She has glasses because she's got an isometropia. She's been treated for amblyopia, but her right eye was still mildly amblyopic. And her ophthalmologist had recommended surgery to correct the right ptosis. Examination found Rose's vision with glasses to be 6/9 in the right eye and 6/6 in the left eye. And there she is with about 2 millimeters of ptosis of the right upper eyelid, left upper eyelid in normal position. Well, it would be easy to just simply accept this and go and examine Rose's right ptosis, check the levator function, the width of the palpebral fissure, the MRD, and then agreed that it's a right ptosis and referred Rose back to her ophthalmologist for surgery. But as pediatric ophthalmologists, strabismologists, we trained that each patient needs to have a full examination. And as part of the examination is testing ocular motility. So the first thing that I do is cover the fixing eye and see and what I thought was the fixing eye and see what happens. And when I covered Rose's left eye, her ptosis corrected and her left eye went up. So she's got a left hyperthermia. So what's going on? So the next step is the head tilt test. Tilt to the left hyperthermia, tilt to the right, no hyperthermia. Check ocular movements and right superior oblique, normal action, left superior oblique, under action. So Rosie has a left fourth nerve palsy. Because her right eye is mildly amblyopic, she's fixing with her left eye, with the eye with the paretic muscle. And so she has a pseudoptosis. So Rosie could easily have undergone the wrong operation under the care of the ophthalmologist, who would have operated to correct her right ptosis, at the end of which she would still have had her left fourth nerve palsy. So with Rose, I recommended a left inferior oblique myectomy. So this, in hindsight, everything seems easy. And this, look, you think, how could someone have missed it? but it had been missed. My third patient is Xavier, a 4-year-old. At the age of 2, he developed esotropia. He attended an ophthalmologist who found him to be quite significantly hyperopic and prescribed glasses, the left eye being more hyperopic than the right. He'd made a diagnosis of accommodative or part-accommodative esotropia. That esotropia wasn't fully corrected with glasses. The left eye was amblyopic, so quite correctly, the ophthalmologist commenced treatment with part-time right occlusion. Xavier has 2 older siblings, 2 sisters, all looked after by the same ophthalmologist. Both have hyperopia, both wear glasses, their strabismus is corrected. So the ophthalmologist expected Xavier to follow suit and just wear his glasses, strabismus would be corrected, and amblyopia reversed with part-time occlusion. Well, despite excellent compliance, as the parents kept telling the ophthalmologist, vision in the left eye didn't improve, but in fact slowly deteriorated. The ophthalmologist blamed the parents. He berated the parents, told them, you're not patching well enough, you must patch more, we've got to fix the vision. Well, the parents decided to seek a second opinion. So I saw Xavier, he was 4 years of age. His vision was 6/6 in the right eye, 6/36 in the left eye. He had a left esotropia, 10 prism diopters at distance and 15 prism diopters at near. He had poor left fixation. I refracted him. I agreed with the ophthalmologist. The glasses that he had were quite correct. So what's the next step? We have a look. We look in with the ophthalmoscope, and Xavier had optic atrophy, left eye more than the right eye. So organized investigations, an MRI of his brain and orbit, and he had a craniopharyngioma, with the craniopharyngioma pressing on the optic nerves and causing optic atrophy. So his management was, next step, neurosurgery. He underwent the neurosurgery very successfully. Unfortunately, the vision in his left eye didn't improve. He remains with 6/36 vision, but his strabismus was stable and he's continued to progress well. So these are 3 patients I've spoken about where there's been a trap, and traps are easy to fall into. How do we avoid falling into a trap? First of all, we've got to listen to the history carefully and believe the parents. The parents are seeing this child every day. We see them at our consultation. So believe the parents. Rely on a careful examination. Examine every child thoroughly. Even if they present with a ptosis, still do a full examination, including cover tests. Always look at the optic nerve and retina carefully. Remember, strabismus may have systemic associations. They come to us with the strabismus, but the eye is part of the body and connected to the brain. Don't become complacent. And something I tell all my trainees, even when you see something like this, it's easy to be critical, but don't criticize your colleagues, because the same could happen to you. I know it's happened to me. I've missed diagnoses. We all miss diagnoses. And remember, what goes around comes around. Be kind to your colleagues. So we've looked at 3 cases which are, in hindsight, very easy, and you wonder, how did an ophthalmologist or pediatrician miss a diagnosis? It could happen to you. Thank you very much for listening. I hope that we, with COVID-19 coming under control, we will have the opportunity again to travel and meet face to face, and you will all have the opportunity of coming to Sydney, and I'll have the opportunity of returning to India and to Chennai. Once again, thank you very much for inviting me to be part of your workshop.
Thank you, Dr. Martin, for that wonderful eye-opening talk.
Wonderful.
It was really amazing, the examples that you gave, which, like you said, many times, if the findings do not correlate with your expectation, it is very, very important to probably re-look into your diagnosis, and if you might find something like this, which in that third case was actually even a life-threatening condition. So I understand as we become seniors and we keep practicing, sometimes we take things lightly, but this is like an eye-opener. At every point, if things do not match what you expect, have a re-look. And sometimes in our hospital, we have a very good support system of all our seniors among us. So we take second opinions if we think something is not right. Thank you, Dr. Frank Martin. Yes, sir, any comments, sir?
Very nice.
Thank him.
Yeah.
Just Frank Martin, I think, replied in very promptly within an hour to get his acceptance for this lecture. That's wonderful eye-opener. Thank you, Frank, once again.
So, panelists, anyone want to talk? Any comments about Dr. Regarding or in the context of Dr. Martin's talk? Meenakshi ma'am, Dr. Sumita ma'am.
I just wanted to say that I think if we do ever again have lean times, I know we've become very busy again. I think this would be a great exercise that we could even collect one case a day, and they would form a wonderful collection of cases to teach with, our own SN collection. So maybe we'll, for a rainy day, as they say. So maybe we'll watch out for these cases, which are good teaching cases. But I think as always, Dr. Frank Martin's lecture was brilliant, and he has given us a wonderful idea. Thank you, Dr. Frank Martin.
Thank you very much, sir. Hope you are staying with us, sir.
Yes, I'll be staying with you.
Thank you very much, sir. We need your comments for all the.
We have a very interesting program. I look forward
Thank you
to
so much.
listening.
Thanks for being with us.
Thank you, sir. Now I request Dr. Jayanthan to just have an overview of the program for today.
Thank you, ma'am. So, followed by our keynote address, we'll be starting our program. The first talk will be by Dr. T.S. Surendran, sir. Ma'am, you can introduce, sir.
So, sir, yeah, of course, doesn't need introduction. He's my teacher, one of my teachers, and he's a teacher to most of us in this panel today. And he's our Vice Chairman of Shankar Nethralaya and Head of the Department of Paediatric Ophthalmology and Strabismus in Shankar Nethralaya. So, sir, we'll have your talk now, Preparing for Strabismus Surgery. I think we'll introduce all the speakers and then go to the talk one by one. Yes, Dr. Jayanthan?
Yeah, that'd be better.
Yeah.
Yeah.
So this talk by Dr. T.S. sir will be on preparing for the Strabismus surgery, the veteran's experience. So the next talk will be by Meenakshi Swaminathan ma'am. It will be on what's new in amblyopia treatment. A few words about Meenakshi ma'am.
Ma'am is a passionate teacher. When you enter her room with a complaint, with a patient, you automatically switch to a student mode. I love taking inputs from her at any point, and she doesn't hesitate to give inputs regarding anything, not just ophthalmology actually. So ma'am will be talking on amblyopia.
The next talk will be by Dr. Kavita Kalaivani ma'am. She is a senior consultant at the Department of Pediatric Ophthalmology. It will be on the most awaited talk, is myopia controllable? The most debated talk in the, most looked off by most of the practitioners. So we are looking forward for your talk, ma'am. So next will be by Dr. Shruti, the pediatric ophthalmologist from MNI Hospital, Chennai. She is more compassionate about her pediatric ophthalmology. If she is not with her patients, kids, she'll be with her kids always. She'll be talking on the strabismus, to operate or not to operate. So next topic will be by Dr. Akila Ramkumar on the topic, the art of prescribing glasses. A few words about Akila.
Akila is a very good friend. She shares the room next to me, and she's a very good colleague, and she has very good experience in managing complex strabismus and pediatric cataracts as well. So she'll tell us about how prescribing glasses is an art or a science.
Thank you, ma'am. The next talk will be by Dr. Murlidhar, the head of pediatric ophthalmology and neuro-ophthalmology in the Eye Foundation, Coimbatore. He's been an alumni of almost all the premier institutes from north to south, and he'll be giving a talk on nystagmus. Let's make it simple. The subsequent talk will be by Dr. Sumita Agarkar, ma'am, on beyond pediatric cataract surgery. The end is the beginning. A few words about ma'am.
Yes, yeah, ma'am. Of course, is our deputy director. She's the go-to person to anything and everything regarding pediatric cataract management. And she will tell us about cataract surgery in children does not stop at the surgery. It actually begins. So we are waiting for your talk, ma'am.
Thank you, ma'am. And the last talk would be by Dr. Anthony Arogya Das Bhaskaran. He's associate professor at the Institute of Ophthalmology, Joseph I Hospital. He's an alumni of Aravind Eye Care System. He'll be talking us on the allergies and red eyes in children. Welcome, Dr. Anthony. And that's a program for the day. And without waiting much, we'll move on to the first talk by Surendran sir.
Thank you, Jayantan and Kavita, for the wonderful introduction. Sure, you can share your screen, sir.
Right. I think I don't have any slides. I think Kavita pointed out very clearly that it will be a veteran's experience. So what we go through for strabismus surgery, I thought I will share. And I think after the regular history taking by what we do at Shankar Nethralaya, I'm just going to share. After doing the regular history taking, then I think finding out whether any allergy is there to any medication, and then the previous surgery, whether it has been done, or I think the patching, whether it was done like that. I think detailed history is done by the optometrist. They not only do that, they also do a dry retinoscopy, and then they measure the prism bar cover test for the strabismus cases. And they themselves will diagnose whether it is esotropia, exotropia, which eye is dominant, etc., extraocular movements, etc. And then I think they dilate and send it to us. Except accommodative esotropias, we normally dilate with the conventional cyclopentylate and tropicamide. And I think atropine is indicated only in cases where we suspect high AC-ORA ratio or accommodative esotropias. After this brief history and the dilation, they also check the anterior segment examination to rule out any cataract or glaucoma, etc. So our job as a strabismologist is, again, I think, recheck the retinoscopy value and then remeasure the orthoptist measurements and recheck again the extraocular movements. Because many times the children less than 2 years and all, it's very difficult to find out the extraocular movements. And then also it's important to check whether there's any face turn or head tilt, etc., or cyclovertical squint and syndromes like Duane's, Brown's, etc. And after all this, I think we just suppose, I think we decide to do the surgery. I think explaining to the parents is very important. Explain to the parents to that extent that first thing I always tell that the second surgery is always a possibility. Because though I think I have done about 25,000 squint surgeries, that 25 twins and 1 triplets is my score. That's why I think Kavita put it as veteran. So what I do is, in spite of that, I think the results are not more than 80% or 80 to 90% we get in the first attempt. We always fail. I think we go for the second. Sometimes we go for the third. So this has to be told to the parents. That not that like cataract surgery, I think we don't give that 99% success rate. And after explaining to them, we also tell them that the risks of anesthesia and even death can take place. That is very important to convey, though it is very difficult to convey to the parents. And then I think we just show them the plan of the surgery. I think there's a picture of the muscles. We tell them that inferior oblique is little thicker in particular case or something like that, and then tell them that which muscle will be recessed, which muscle will be resected. A brief conversation with the parents. And after explaining everything, you also need to check the conjunctiva very clearly, because few occasions, I think people have told that they have not been operated, but they would have got operated, because especially sensory exotropia or sensory esotropia, they are very scared to get the other eye operated. So I think they will not tell you that they have been operated. So it is mandatory to check with the slit lamp whether any scar is there. So don't believe especially the adult strabismus. After detailed explanation to the parents, they just go to my secretary, and she will explain the date and the fixing up through the surgical fixing center. Surgical fixing center gives them appointment, and normally I think the regular hemogram, then probably I think if required, I think ECG is also taken, echo, and premature child or some syndromes can be there, Alport syndrome. And these actually, our system right now is, we have a tie-up with Rainbow Hospital, where the pediatricians have taken over the checking of the child, and also till the child is discharged, is their responsibility. And after they give clearance, they might do, as I told you, X-ray chest also. And they just have that gradation by the anesthetist, ASA 1, ASA 2, like that. It goes up to ASA 5. ASA 5 and 4, here we need to get the consent for high risk. And I think we again explained to the parents that there is a high risk involved. Sometimes I think you had to operate delayed milestones child, etc. So we explained that high risk is involved and get their consent. And sometimes I think they disappear. It is well and good enough. I think don't take any chance. So explanation at every stage is very important, because life is precious after all, whether it is child or an adult. After all these investigations and clearance from the anesthetist, we also check for some particular community which has this choline apnea. I think nowadays choline is not given, and also very rarely, I think, malignant hyperthermia, that also goes familiar. I think but that community, I forgot. Vaishya community.
Vaishya.
Yeah, they have a problem, because I had in the early 90s, I had one patient who had 7 hours to recover. He developed this choline apnea, and once I also had malignant hyperthermia. which had to be shifted to Apollo Hospital. Then later he recovered. So these possibilities are there. And after anesthetizing the child, I think when the admission takes place, again I go and check in the wards, which eye, which muscle, and which patient. Three things are very important because I think with the high volume, I think our record has been one day we performed 21 surgeries under general anesthesia. That was again in the 90s. So we don't know what child walks in and what muscle you are going to operate. And accident can take place, fortunately, because of our grading. 5-star this thing. I think we have not had any problem. So I go and check in the ward. Even if it is 20 cases, I think we go and check. Every child which has been admitted, we don't go to the theater before checking the children. And confirm again the muscle, again confirm the readings. Very rarely I have changed the plan. Whatever plan you have planned earlier in the outpatient, I think hold on to that, because sometimes you may have a sixth sense telling that why don't you do instead of 7 millimeters, 8 millimeters a session like that. But I think invariably our first OP, this thing I think always holds good. Then after seeing all these patients, I think they are given pre-medication. I think trichloril and as a sort of sedation is given about 45 minutes, and it's very important to have NPO, nil oral, at least we insist on 7 to 9 hours. And invariably when we start the children in the morning, because I think they take only the previous night some food, and they just take I think couple of sips of water, etc., and then come directly, and they all report at 7 o'clock in the morning, 7 a.m. And so the list goes on till 5, sometimes even a little later also. After your this thing starting the case, I think make sure again, I think there will be a small this thing in the hand, the identity of the child with the MRD number. And before anesthetizing, again you recheck. At least you know whether it is esotropia or exotropia, and so that we don't mix up the muscle or mess up the muscle. And then I think anesthesia is given, and we have expert anesthetists who have a lot of training in pediatric ophthalmology. And even I think many times they have done one-day baby also. So the mortality rate is very, very low at our center. Practically, I think all of 2000 and all, we have not lost even a single case. There were incidences wherein 26 cases of anesthesia were given in only that 5 operation theaters in Maiko block. The JKCN block separately anesthesia and pediatric cases will be going on. But one particular day, because I think the retinal surgeons also perform some surgeries in the adjoining theaters. I take 2 theaters, and sometimes they check retinopathy of prematurity and retinoblastoma follow-up, etc. So that mix-up also should not be there. That child should not be brought to the squint, because they also may show strabismus. So on the whole, I think checking, rechecking, rechecking is very important. Then I think as per the plan, you go ahead with the surgery. And I don't put any patch except if there is a block given, peribulbar or retrobulbar. And most of the time, the anesthetists give the block. And whenever it is under local anesthesia, they also give little sedation. I think always children are given, I think, propofol to start with, and then they find out the vein, then only intubate the child. This is Shankar Netralaya protocol. And after finishing the muscle surgery, it takes about 6 minutes each muscle. And whatever number of muscles you have, you can multiply and see how much time it takes. After that, I think no patch. And then the parents are explained that the surgery has gone off well, and then there may be slight blood ooze from the nose or from the eyes. And also vomiting is a possibility. Sometimes antiemetics are given, and also analgesics are given. And sometimes we do inject a little bit of xylocaine injection into the muscle, and some anesthetists prefer that. The post-operative pain is much less, according to them, that if you inject a little bit of anesthetics into the muscle. And I think overall, after the surgery is over, I think we send the fellows or postgraduates to go and recheck in the ward whether everything is all right. And we discharge the patient and ask them to come the next day. And post-operative checkup is done. The possibility of diplopia is also explained beforehand. Apart from telling that there is a possibility of second surgery, possibility of diplopia is also told. Otherwise, intermittent divergent squints, you tend to overcorrect a bit, and little ESO also can cause an annoying diplopia. And with the intermittent divergent squint, earlier he would have been having hemiretinal suppression, and there may not be diplopia. So this is very important to convey. And force duction tests are done, especially when we have doubt Duane syndrome, etc. I don't do it in all cases. And that is in a nutshell about the journey of going through surgery.
So thank you, sir. It was a surprise that this is the journey that we were looking at. I mean, it's been a very long time since somebody has spoken, literally only spoken without the aid of audiovisual aids. So thank you, sir. Yeah, you have
really fantastic, sir.
Walked us through what really happens once a patient with strabismus enters the hospital and leaves after management.
I didn't want to tell how much to do 1 millimeter recession, corrects 5 to 6 prisms, and whether Hirschberg method is better, or we counter check with PBCT and all. And Professor Martin also already has given some initiative, what all to be done. So
absolutely, sir. This is a
very
different way of.
Thank
you so much, sir.
Another eye opener, I would say, TSS, because I have seen it firsthand, working with him as a postgraduate as well as a fellow in Shankar Netralaya. I know how he checks and rechecks, and completely, he doesn't give it to anybody else. He does it personally, every child, that's fantastic, sir. I think we have learned a lot from you, sir, today.
So another important milestone, I think I shared with you, 25 twins I have operated, and also 1 triplets. Always I cherish that memories.
Amazing. That should be a world record. Yeah.
I don't know.
Dr. Frank, do you have any comments on Dr. TSS's journey of the patient?
Well, he shared his experiences. This is just huge. I remember the first time I met him, I was telling him about these 8 very interesting patients that with a condition that I'd seen over 10 years. And he just very, in his humble manner, said, yes, we see about 8 of these every week. So his wisdom is always worth listening to, because he can talk from experience. And strabismus is very different to, if you've got to feel it, it's not something that you can read in a book and understand. You've got to experience it, feel it, and what you do, it comes down to, you might have a plan and then you're operating, and your plan has to change completely, because parents don't know what the past operative, like a child who's had 2 or 3 operations, they might think it was all on the right eye and might have been on both eyes, and you get a surprise. So you've got to be ready for these surprises, and this is what Dr. Surendran's has able to share, and is always worth listening to. Thank you very much.
Thank you, Dr. Martin.
Say.
Now, I think we'll move on to Dr. Meenakshi ma'am's talk on what's new in amblyopia treatment.
Is it clear? Is it visible? I'm going to just go to the slideshow.
Yeah, it's visible. Yes.
Clear.
Nice template.
Thank you once again for this opportunity. And where's my first slide? I'm sorry. Yes, because I need this slide here. So what's new in amblyopia treatment? This is, and Dr. Meenakshi Swaminathan, as I've been introduced, no financial disclosure. So I have 8 minutes for the talk and I'll try to speed up. And unlike Dr. Surendran, who, shared his wonderful experience, a lot of mine is on what's new. So I am learning about the new things as much as you all have been are learning. So I'm just going to share whatever I have learned in the last few years. So 800 AD in Baghdad, Thabit ibn Qurra, he suggested that we have to patch the eye for amblyopia. 2021, we are still doing the same. Really? Is there no advances at all? Well, a few, so I'm going to share them with you. So it's not unusual for us to see a scenario like that, where a 23-year-old engineer diagnosed recently as anisometropic amblyopia comes and says, you know what, can you not do something for me? You know, my parents never took me to an eye doctor and I just got diagnosed last year. Can you not do something? Maybe there's an 8-year-old who's intolerant to atropine and cannot patch due to evening tuition and tennis classes. What do you do for him? So that is where recent advances come in. So it is based on the principle of restoring cortical plasticity and reducing intraocular suppression. And this have received considerable attention as a therapeutic strategy for amblyopia. So it also has been recently thought, why are we so obsessed with only vision? Did 636 become 618? Did it become 69? Why not focus on binocularity? So those are the recent thought processes going on worldwide. So first, we're going to look at behavioral treatments. So the first one is perceptual learning. What is it? It's a process whereby by practicing certain visual tasks, it leads to improvement in visual performance. And the brand name that we have available now in India is Revital Vision. It's a non-invasive software-based therapy where Gabor patches are the target for visual training, and it helps in facilitating the neural connections at the cortical level. What are Gabor patches? This is what they look like. And how does Revital Vision help? It not only improves vision, but also improves contrast sensitivity. Gabor patches match the shape of the receptive field in the visual cortex and activates efficiency. That is how they work. Is it the same as CAM stimulator? Some of you who might have seen the CAM stimulator in the past? No. CAM is brief and passive, versus perceptual learning is active and prolonged. So in this very year, we should have AMPLE, the treatment results of AMPLE, which is amblyopia treatment through perceptual learning training in children, which comes out of Switzerland. The recently published study in 2021 from Spain also showed that there is efficacy of perceptual learning-based vision training as an adjuvant to occlusion therapy. So this FDA-approved Revital Vision is now available in India, and there is your contact. Video gaming. What is it? Playing action and non-action video games with a better eye occluded. Again, it induces cortical plasticity and improves visual functions beyond the sensitive period. Remember our engineer of 23-year-old. So video games induce a reduction of noise and an increase in sampling efficiency. So the Dig Rush in the US was the first prescription gaming that was FDA approved. And if you open the internet, there are many lazy eye apps that are available as well. What is the verdict? Well, it has addiction potential. There's an article I found from JPOS 2017, where from RP Center, where they've used as an adjunct to occlusion and anisometropic amblyopia and found it to be useful. We move on to the next hot topic, which is Dicoptic Training. And again, we have something called the Binocs, which I think many of you are familiar with. It's a novel cloud-based comprehensive binocular vision assessment and management software. And in Binocs, Dicoptic amblyopia therapy is what we are interested in. So it does have a diagnostic mode which we're not going to go into, which basically looks at various aspects of binocular function. And then it also has a therapeutic mode wherein the dicoptic amblyopia therapy is featured. Now, the patient basically uses the ANF glyph glasses for playing the games. Color saturation of the fellow eye is kept low to facilitate binocular summation. Size and speed of the target improves based on the performance. So as the patient gets better, the target size and the target complexity keeps getting more and more challenging. The binocs is effective for patients with anisometric amblyopia, but the angle of deviation needs to be less than 5 prism diopters. So really for strabismus, it's not that useful. So this is what a screen of the binoc supercar looks like. There is a way you select the eye, adjust the color, and the near visual acuity of the fellow eye and the amblyopic eye, and then you go. So there are several therapy protocols which you can follow, which is monitored by the optometrist or the therapist at the other end, or yourself. It's worth a try, especially because the focus is not just on vision, but on binocular vision. And dicoptic stimuli are available in institutes. And there are many, many publications, particularly by the group from Dallas, headed by Birch et al. On the efficacy of dicoptic therapy. Okay, moving on to the next one, which is virtual reality, which is now marketed in India under the name REMED. So REMED is a virtual reality plus dicoptic based game therapy. Again, it has several modes, and patient's performance again can be monitored with the help of a tablet by the therapist. There are 7 different games with different levels of training, which can keep the patient engaging. And the wonderful thing about REMED is that you can also incorporate settings for strabismic amblyopia by neutralizing the angles. So that's what a typical REMED virtual reality screen looks like. And that's the monocular percept. And if the patient now starts using both eyes, the patient will appreciate everything and then can actually play the game. That's the binocular percept. Now, I want to also share our very own Dr. Santan Gopal, ex-president of the All India Ophthalmology Society, has his invention, which is the OrthopTech. And these are a couple of slides that he was kind enough to share with me. This is a magnocellular stimulator. It's used to treat different types of amblyopia in patients between 6 and 50 years of age. And they've also been followed up for 6 months, and he found that not only the vision improves, but also stereopsis and binocularity. And it's basically a screen with multiple rows of LED, and it's a 30 minutes exercise. And more data is coming out of Dr. Santan Gopal's practice as we speak. What about alternative therapies? Well, there is the liquid crystal eyeglasses. And so if you have the rich patient, it's $450 a pop, but it's better compliance. There's no ugly patch. So the filter in the fellow eye alternates between opaque and clear. And there are prospective studies showing that it is of equal efficacy to patching. And then of course, you have acupuncture, and there is a study from Hong Kong, which showed the efficacy in anisometric amblyopia. Well, look at the little baby with all the needles sticking out. I don't know if our Indian babies are going to cooperate. So then also I came across physical therapy. That is the short-term occlusion of the amblyopic eye, not the fellow eye, combined with physical exercise. This is a paper that came out of Italy. After 6 brief training sessions, visual acuity improved in all the 10 patients, and 6 of them also recovered stereopsis, and it preserved this up to 1 year after training. You know what? You get your exercise in, and you get your vision back. Not a bad suggestion. What about pharmacotherapy? Well, dopamine has been found to be reduced in the retina in the deprivation amblyopia. Increasing levels of dopamine in the retina has been found to have a beneficial effect. We already know about levodopa and citicoline. They work temporarily and as an adjunct. But now we have treatment of residual amblyopia with donepezil, and this has just been closed in 2021. We have to wait for the results to come. How about the effect of combined patching and citalopram on visual acuity, which is citalopram is an SSRI that again showed that it is efficacious. There is not too much data, but there's just one paper from Thompson Group in 2019. I also found a sub-anesthetic ketamine reactivates adult cortical plasticity to restore vision from amblyopia. Seems to be an experimental paper in Current Biology. If you want to read more about emerging therapies for amblyopia, recommend this article, which is Open Access Seminars in Ophthalmology by David Hunter Group. This is a fascinating area of research. So I conclude by saying that it's useful for both adults and children. There are a lot of exciting therapies out there that are now available in India. We can use them as primary and as adjunct therapy for our child and adult patients with amblyopia. Thank you so much for this opportunity and a patient listening.
Wonderful talk, Meenakshi.
Thank you.
Wonderful. See,
Wonderful.
till very recently, everyone believed or everyone thought amblyopia is a very colorless, bleak kind of thing, especially when you cross the age of 10. Now, like ma'am has clearly said, there is hope at almost any age if you're diagnosed recently to have amblyopia. So I would request Dr. Sumita ma'am to have any inputs.
I think Meenakshi has covered it very nicely, everything. But yeah, one important thing to remember here is that there are types of amblyopia which respond to the therapies and which don't. So I think none of these therapies which he mentioned, a lot of them don't work for deprivational amblyopia. A lot of them don't work for mixed mechanism amblyopia as well as they do for anisometropia and strabismic amblyopia. So that distinction should be kept in mind before offering patients these newer modalities. Thank you.
I just have one question, Kavita.
Yes, sir.
What is the oldest age you can treat amblyopia?
Any
Frankly, now, Mohan, we're offering, I'm offering patients even in the mid-20s, late 20s, perhaps maybe 30, but easily patients in their 20s.
I had a patient and who lost a good eye because of injury. Other eye was amblyopic 6/60 and he improved to 6/9. He was about 45 years or 47 years.
Yeah, that's fascinating. That's well known actually, and it's described in literature. Yeah, it's one of those amazing things that we really don't fully understand.
Yes, ma'am. I would also like to add a comment. Actually, the term plasticity in children, I don't think it applies anymore. And more we see, the more and more we try, we get very good results for adults as well. They say there is a stop signal at a certain age, and by removal of the signal with the right kind of therapy, like Dicoptic therapy, it can actually cause induced plasticity in adults as well. So it's an interesting thought.
So the take home probably I would say is we have to offer or attempt at any age if the patient presents to you. If they're willing to try, you have to give an option. You shouldn't say it's not treatable if they had not been ever treated before. So with this, we'll go on to the next talk.
Yes, thank you.
And I think it's a talk on myopia by myself. And I'm happy to introduce Dr. Vishwanathan sir, who's agreed to stay with us for this particular talk because I wanted his one or two inputs on, because he manages most of our myopia patients in Shankanetralaya. He runs the Department of Myopia Clinic. So I'm sharing my presentation. So like amblyopia also, myopia till very recently, we all, or at least everyone used to say that, is there a cure? I remember myself, I hear myself saying that it is a defect, it is not treatable, it is not curable. We have to wait till the age of 18, 19 and think about some options. But it is not that case anymore. And it's very happy to know that there are few options in our hands for patients that we can offer. So is it a disease or a defect, and why does myopia progress? So age, genes, external factors, the activities that they do, and sometimes the intervention. So these are the things myopia is linked with. So why do we bother if myopia progresses? So for the patient, it is a stigma, of course, to wear thick glasses. Of course, functional issues. There are a lot of things you cannot do when you have to wear glasses, like sports, limitation in activities, job issues can limit patients, vision-threatening complications as the myopia progresses. And for society, it's an economical burden, changing of glasses, treatment of complications, and rehabilitation. So what is myopization? The lens for failing to stretch, accommodative lag, eyeballs became prolate, and peripheral relative hyperopia and defocus happens, and the patient becomes more and more myopic. So how do we identify risk factors? Genetic and environmental factors play a role. Twin studies prove this. Number of myopic patients, increased prevalence, and family study also proved that genes has a very strong role. Environmental prevalence, we all know that Asian countries have a very high prevalence, which has to probably have something to do with the environment. Ethnicity, near work, of course, has a constant or consistent link to progression of myopia, and time not spent outdoors has a deleterious effect. So what are the interventions that people have tried? So there are 3 groups: pharmacological agents, optical spectacles, and contact lenses. So low dose atropine, these are the things which after trials have been proved to have some benefit in the recent past. So this is how optical and pharmacological therapies are classified. So let's first see bifocals and progressive and how they work. So the mechanism of how bifocals or progressives work is the higher lag with near work among myopes is a very known mechanism. So there is a hyperopic defocus when we prescribe bifocals or progressives, which leads to axial elongation. So with this mechanism of progress of myopia, a hyperopic add correction and a bifocal in the form of bifocal or progressive supposed to help in the progress of myopia. But these seem to have contradictory results. Significant myopia control is reported in various studies, but it's not replicated in all studies consistently. Similarly, COMET study about progressives initially showed better results. Subsequent studies, not too much. So statistically significant, but not still clinically relevant. So these were tried and now not so popular methods of myopia control. Multifocal lenses are very promising lenses now in the form of contact lenses as well as glasses. This is what is now the current thing. So how do they work? So traditional correction Q for axial length, axial elongation. The aim is to create a peripheral myopic defocus to control the progression of myopia. So MyoVision is one type of multifocal spectacles manufactured by Zeiss company. So here they give a central distance zone with peripheral addition lenses around the central zone of clear actual correction of myopia. So this is supposed to have 31% efficacy in control of myopia, but there is no clinically significant difference. MyoSmart is now a very promising type of multifocal spectacles manufactured by Hoya company. Again, here they work in the principle, they give a central clear correction lenses of 9.4 millimeters, which doesn't affect the child's vision for distance. And there are 4 defocus points. It is called DIMS, defocus incorporated multiple segments in the periphery. 33 millimeters of peripheral zone is provided. So this is how the pupil size is very important. Center of the lens and the pupil size has to match. So the patient does not have difficulty in distance vision, but it is supposed to have a very good effect on control of myopia. So myopia progression of minus 0.4 diopter at 2 years. At the end of 3 years, 0.5 diopter is seen with these lenses. 60% efficacy in axial growth also is reported. Very good compliance because it doesn't involve any drugs or anything, and vision is not affected. The child easily adapt to the peripheral blur after a few days, and 70% children progress very less in 1 year follow-up. So contact lenses, yes, they also seem to have a similar role. They are multifocal contact lenses, central distance correction with peripheral addition, simultaneous myopic defocus in the periphery. MySight lenses are the contact lenses which have the multifocal facility, approved for myopia control. So they have a treatment central zone and a correction zone. They are also found to be effective in these studies. A mean myopia progression of minus 0.51 in the treatment group compared to the non-treatment group. There is a good reduction in refraction as well as the axial length elongation. So they work with an extended depth of focus lens design. And yes, orthokeratology has been in practice for the past at least 10-15 years, but now it is gaining a little more popularity. It works on reverse geometry lenses, which has to be worn overnight. Temporarily flattens the cornea when worn in the night. At least 8 to 10 hours of wear gives 8 to 10 hours of clear vision. It works for a myopia of up to -5 or -6. It works on reducing peripheral hyperopic defocus and provides clear vision in daytime along with myopia control. So finally, we have what is now the current standard of care. It's almost become like a standard of care, low dose atropine. So low dose atropine of 0.01% and 0.05% atropine is controls progression as well as axial length elongation. It has been showing consistent results all over the world by studies like ATOM2, LAMP studies, and even an Indian study. The main good thing is it's a drug, but very, very limited side effects, so which is a very good thing. So our own study of 60 children in the past 1 year with 83.3% response to treatment, the mean increase in axial length is 0.18 millimeter and 0.25 millimeters in the right and left eyes respectively with no side effects. So this is a very encouraging prospect. The questions yet to be answered though are what to do if for non-responders and why there is a disparity between refractive error and axial length elongation, especially in Indian eyes. And can we extrapolate to other types of myopia like aphakia, pseudophakia? So those children also have axial length progression. So can we use atropine on these children? So these are the questions to be answered. So how do we choose? Safety is very important. Spectacles relatively safe and no adverse effects. Contact lens also, there is a little safety concern, especially the ortho-K lenses. Pharmacologicals are relatively safe. Atropine has been studied, various studies show the safety, and patient education is very, very important. And what patients benefit, selection is also extremely important. So from now, where do we go? Every diopter of control improves quality of life. That's the belief with which we want to try to treat myopia. Move from prescribing single vision glasses for managing myopia, increased options to choose, and fast changing field with newer strategies. And we can sometimes combine pharmacological and optical strategies. So how do we choose? So the algorithm is with the onset of myopia, first visit, you do not do anything. You follow 6 monthly. You balance of very near vision activities and outdoor activities. Then if there is a progression of more than 0.5 diopters, then you can start on low dose atropine, explaining all the effects. So low dose atropine, you start and there is a less progress of myopia, you are satisfied, you can continue the atropine. And you can either add or switch to MyoSmart lenses. Progress more than 0.5 in the first follow-up, then you can either switch to higher concentration or twice a day concentration or continue the atropine and add MyoSmart lenses. So restrict adjunct therapy is very, very crucial. Restrict gadget and near activities, improve outdoor activities and sunlight exposure. So to summarize, myopia is no more an untreatable condition. Customized treatment options are available. And wise and timely intervention is it's necessary. Thank you so much.
Lovely talk, Kavita. Lovely.
Thank you, sir. And I request Dr. Vishwanathan, sir, to please say a few words about how in SN we do the myopia.
Yeah, I think you have covered most of the points, ma'am. Just to add, few things or to reiterate few things that you said. One of the things that we do at SN is, suppose a patient is seen for the first time and we diagnose him or her as having myopia. And if the next time when we see in the follow-up, if they are progressing fast, so how do we, describe the faster or progressive myopia? Somebody who is progressing more than half a diopter compared to the last visit. So that is how we describe whether it is a stable myope or a progressive myope. So if we see somebody progressing fast, so we also document the axial length because that is considered to be one of the gold standards now, and based because even whether a treatment is working or not is based on the axial length measurement. So we document not only the cycloplegic refraction, along with the cycloplegic refraction, we also document the axial length. So these two are the key measurements. And then either low dose atropine is the, as you said, the first line of treatment is the low dose atropine. And what we have seen is for about 10 to 15% of the patients, low dose atropine is not working. That means either the for most of them, the cycloplegic refraction is getting controlled, but not the axial length. So what do we do? So the literatures have clearly stated that if somebody is not responding, that means both cycloplegic refraction as well as the axial length should be
less than 0.25 diopters and 0.10 mm in axial length. Only then it is working. Okay, so somebody who is not responding means what is the next line of treatment? So as you said, the combined thing is what we are trying now. So with low dose atropine, if it is they are not responding, then we switch to MioSmart lenses, and that is what we have started now. So I'm sure with MioSmart lenses, the literatures have clearly shown that there is control of both cycloplegic refraction as well as axial length. And this is what we are currently doing. And the other treatments are not available like MI sight or other lenses. Currently, low dose atropine and MioSmart lenses are only available. Orthokeratology only for people who are involved in sports and other activities only we are recommending. So this is the summary, ma'am.
Thank you, Krishnathan sir. That was a very clear picture. I want Dr. Frank Martin's experience of myopia control in your part of the world, sir. Is myopia as much a problem as well?
Yes. Myopia is a big problem, same as a worldwide issue now. And I think you summarize what's available very, very clearly. We follow the same as what you do. We give the patient the options, and atropine does work, but not in everybody. And sometimes we have to combine atropine with I've been using atropine in combination with the peripheral defocus spectacles. In the Ortho-K is expensive and does carry a risk to the child. We've seen a number of acanthamoeba corneal infections in patients using Ortho-K lenses. So there's a big divide in Australia between the way the optometrists and ophthalmologists approach it. Optometrists tend to use Ortho-K lenses as their number one. Ophthalmologists, low dose atropine, 0.01%, and if that doesn't work, 0.05%. But we do very much what you've outlined, nothing different. And with COVID-19 and children having homeschooling and spending a lot more time on the screen, this has become a much bigger issue. And when we graph how children's myopia progresses, we've noticed last year during the lockdown period and this year, myopia has spiked. Thank you.
Thank you.
Although in the world, I think in the world projections, Australian children seem to be doing better than anybody else actually, because of a lot of time spent outdoors. So Dr. Frank, I think you are in a slightly luckier zone.
Not enough time outdoors. And children are spending far too much time from a very early age looking at screens. It's the parents who are using it, rather than giving the child something meaningful to occupy them. Easiest way is to give them their phone and let the child play with it, and not a good thing to do.
Thank you, Dr. Frank Martin. Dr. Murli, do you have any points to add?
I mean, there's one issue that we can add 0.05% atropine. The problem is that reconstituting atropine, it is not very stable. So what we have been doing for non-responders is that we have shifted to twice daily 0.01% atropine, and we can reconstitute in the same this thing, adding 0.2 ml of the 0.6 milligram atropine to the Myatro or Kitro commercially available 0.01% makes it 0.05%. So that is what we have been trying recently. We are also going to introduce the MyoSmart lenses shortly. I think it's a very useful addition. It costs around 20,000. The lenses, a pair of lenses costs around 20,000 to the patient.
Yes, nice. Thank you.
Kavita, I have one question.
Yes, sir.
You advocate bigger screens for these children, especially online classes.
Definitely, sir. So the history of myopia management definitely includes how much time they spend on near gadgets, and we always try to recommend and tell them to switch to a bigger screen if they attend classes in a mobile.
Connect the this thing to the TV.
Yes, sir. Yeah. So luckily now that seems to be a very easy option. It's really not a very big financial challenge to screen share in the TV. So many parents are able to do that.
So the question, Dr. Mohan, very good question. The question we ask is that, is the class interactive or is it one way? If it is one way, the smart TV is the ideal thing. If it is interactive is when then it becomes a little tricky. But it's a great question, and it's something that we tell the patients routinely.
You don't require a smart TV as well. You can just, even for a regular TV, what you require is just a Chromecast or Amazon Fire.
Yeah, that's what I mean. That's what I mean is you cast it on the TV. That's what it is.
That's fantastic. Very good. A good message.
Kavita ma'am, regarding the axial length disparity you were talking about, I think that's a common phenomenon that even I am noticing in my patients. There is a disparity between the progression and the axial length measurement. And I was wondering why it could be. It could be probably because myopes tend to have posterior staphylomas, even in mild form. So sometimes measurement errors is a possibility that can be encountered in these conditions. But nevertheless, I also seem to have this problem of axial length not matching up to the progression of myopia.
It's reported in our Indian population. Say, Dr. Vishwanathan's study in our institute, that is what we have seen. There's a slight mismatch sometimes. So probably we need to look into that more. So thank you so much. We'll go on to the next speaker, which is, I'm sorry.
Me, I think.
Shruti. She's going to tell us, when you see a strabismus, do we operate or decide not to?
Okay. So good morning, everybody. And today I'm going to be taking on the difficult challenge of suggesting or trying to answer the difficult questions of to operate or not to operate in strabismus. Now, we know that most of us have existential questions that we want to answer, like to be or not to be. Is that the question? But believe me, strabismologists have a much more difficult question to answer when we say, do we need to operate? And that's because we have 100 ways to answer it, 100 ways to think about it. And finally, when the answer comes, I think we all look forward to orthophoria, but by the time we reach orthophoria, we end up having gray hairs. So before we answer any question or before we want to intervene and do a strabismus surgery, we should always wonder what could possibly go wrong or what is the worst case scenario. That's how I see it. And if we are able to answer, if the worst case scenario is something that's tacklable, then definitely surgery is a good option in strabismus management. Now, let's just see some cases. So this is frankly a straightforward case of an intermittent exotropia. You can see that this patient has a left esotropia. He has poor motor control, seen more than 50% of the day, poor fusion, poor stereopsis, and this is a right candidate for surgery. And definitely the answer would be surgery, and the eyes tend to align well after. But how about surgery in so-called well-behaved exotropias? Now, when you see this child, like a 7-year-old, she has a large exotropia, but she has extremely good control, which means she's able to handle it most of the time, but she has good stereopsis and fusion as well. But the parents are worried about this and we're wondering what to do. In such cases too, I would still recommend surgery because these large angle exotropias tend to be very bothersome for the children, causing diplophotophobia and some form of a distraction from their, especially when they're tired or anxious. So surgery can still be a good option even in good control large angle strabismus. This next scenario, are all esotropias operable? Now, when you see an infant like this with an esotropia on the right eye, you can see here, there are two options to think of. One is surgery. Once you get a reliable measurement, you can go in for surgery. The second option is Botox. Now, if you want to avoid surgery, we can plan for Botox injections up until a point where we can get reliable measurements. But nevertheless, many studies have found that multiple need for anesthesia is there, whereas just doing a bimedial recession as a first stage can bring about good results, at least for the short run. So definitely infantile esotropias are a good candidate for surgery. But how about the older kids who have esotropias? And these are most commonly, if you just give them a good cycloplegic refraction, they end up having corrected squints. And these are refractive accommodative esos which do not require surgery. There's another patient here. We could see that they had a near distance disparity in the squint. And this child had a high accommodative high AC by A ratio with an accommodative esotropia. So you can see that the child was initially put on glasses with a near add of +3 in order to correct the high AC by A ratio. With time, the glasses, the near portion alone were removed because the high AC by ratio was corrected. And further on, the child did well even without glasses. So it's a long journey, but the journey is gratifying because you tend to avoid surgery. You don't have to operate for these kids. So do not operate in such children. In some children, you might have to do half the work of non-surgery and half of it surgically. So this is a esotropia where you can see partially corrected by glasses and the rest of it had to be done with surgery. It's very important to counsel the parent to let them know that the child will have glasses, will have squint when they remove the glasses, but over time it's going to reduce and disappear. So in such cases, yes, we need to operate for the residual esotropia that we see beyond the glasses correction. So like I said, it's a very long journey, but we have to do whatever it takes to reach orthophoria, even if it means we have to swim across the Atlantic Ocean. So we might have to travel by road for a distance, or we might have to swim the rest of the distance, but nevertheless, we need to get there. Okay, so this is a fairly common question that we ask, like, do we need to operate the other muscles? Now, this was a set of twins, a pair of twins that I had operated on. Both of them had exotropia, both of them had inferior oblique overaction, but one twin had +3, whereas the other twin had a +1. So I went the short route and I thought maybe I'll operate the inferior oblique in one and just leave the other and see how that happens. And that really burnt me because that patient ended up having a hypertropia postoperatively with a small inferior, the inferior oblique overaction persisted, and I had to correct that in a second stage in order to get the orthophoria. So always the lesson learned here is due diligence is important. When you see something, when you see a muscle overacting, do not neglect it. Always address the muscle, maximize your surgery, and do all the muscles that is required to bring about the right therapy, right outcome, and don't ignore the inferior oblique by any means. And I'm very proud and happy to be here in front of Professor TSS with my first pair of twins, and sir has done 25 squints as he's already mentioned. And I think this is my first twin and pair of twin. As a student of his, I hope to continue this journey further. Okay, moving on to acute esotropias. Do we need to operate? Now, we do tend to see a lot of kids nowadays with having esotropias as a sudden onset, the AACE variety. And here you see this is a young child who was on who's orthophoric to begin with, but after 1.5 years of age, after a lot of digital time, like more than 6 to 7 hours a day, ended up having this esotropia. But this child did well with atropine. You can see the child is dilated here, and slowly the child recovered with just atropine. But not all cases are this good. You need some of the cases, like this is another girl who had an esotropia who didn't really who didn't resolve with any form of therapy, not atropine or relieving from the lifestyle factors, and ended up requiring surgery. And once the surgery was done, the child did well. So it's important to know that we have to wait for some time in these conditions before we operate. Now, many of us have an inhibition to start operating on nystagmus patients. Here you can see a patient with an exotropia with a large amplitude nystagmus, but they tend to do really well after surgery because their amplitude reduces and their foveation period improves and their vision improves as well. So I also tend to add a TNR, a tenotomy and reattachment of the untouched muscles in order to bring about better lessening the amplitude of the nystagmus, and it works pretty well. So yes, operating a nystagmus is a definite yes for me. Congenital Brown syndrome, well, we do know that that is another situation where primarily they tend to do, primary gaze they do well, but when you see on up gaze, in adduction, you can see that here they have the underaction. They are, as long as they don't have a head posture and they're orthophoric, we can observe them because many of them tend to resolve on their own. If they persist into adulthood, then we can operate on them. Then, of course, the CPEO variety where, it's a little tricky situation. We tend to have a lot of undercorrections in these situations. This patient is one where he was keen on surgery. He had a chin-up position because of the hypertropia and he had an exotropia. He did well with bilateral lateral rectus recession with a half tendon upshoot. You could see that the chin-up was resolved, but he did have a slight undercorrection, which is seen in such CPEO cases. So in CPEO children, you tend to have a little bit of undercorrection. So beware of that, but definitely operable. What about small angle strabismus? So here you can see a small exo. We did a mini tenotomy and she did pretty well. But there is a controversy like whether to observe or surgery. And many studies have found that observation is the same as doing surgeries for these small angle, less than 20 prisms diopter surgery, prism diopter exotropias tend to do well with even observation and with therapy, with convergence therapy, they do well. This is another patient with microtropia. Here you can see the right ESO This is a primary microtropia. You can see the right ESO. Yeah. So this is less than 10 prism diopters. They have anomalous retinal correspondence with peripheral fusion or smaller ESO deviation. They don't tend to do well with surgery. How about children with developmental delay? Here, there is a lot of issues at play. First is you need to get good measurements. You need to, usually they don't have good fusion potential. They have anatomical variations. Prior surgery has been done, then that makes a difference, and anesthesia. So here, invariably, they tend to be overcorrected. So it's very prudent to undercorrect a little bit, at least 1 mm. So I'm going to skip through these slides for want of time. This is just to show that this is a strabismus caused because of tight pterygium, and you can see this muscle, the pterygium pulling the eye inward. It's very important to rule out such cases before you go in and jump into muscle surgery. Okay, this is my last slide. Here you can see this was a patient who had a trauma and a blowout fracture, and you can see there is a lid issue. This patient underwent a floor repair, and after surgery, this is what happened. So it is not a question of should I operate, but when should we operate? This is post-op day 1. We immediately intervened because we were worried something happened to the inferior rectus during the floor repair. And as we went in, we saw that the inferior rectus is actually quite okay. It was intact, and we were able to trace it all the way back into the orbit, and it was intact, and still a mystery why the inferior rectus stopped working. So what we did was we pulled out the inferior oblique and we attached it to the inferior rectus, and also did a little bit of superior rectus recession, and the eye came down to a certain bit. So in a nutshell, whom to operate, we need to find out. We have to diagnose the right esotropia. We need to operate the nystagmus. Kids with developmental can be operated. Rule out pseudostrabismus. Time the surgery properly. Maximize the outcomes. Choose your right muscles, and ultimately do no harm. And remember that. So thank you so much to Tnoa. Thank you, Mohan Rajan sir, Jayantan sir, and to my mentors for having me here today. Thank you.
Wonderful, Shruti. I love your conclusion. Yeah, that's so. Before we know what to do, I think it's very, very important to know what not to do. From the panel, any comments? Sir, ma'am?
Just to convey that, I think she presented very well, covered most of the topic like Rajdhani Express. This thing that nowadays executive bifocals are not available. I think Shona Vishwa, I don't know whether he left. So I tend to give progressive, and still I think I am trying phospholin iodide for the non-cooperative children who actually could manage to get phospholin iodide for accommodative esotropia and high AC or A ratios. And always measure the true divergence excess by taking the child to a infinity, because what we measure in our room is a 3-meter chart or 6-meter chart. We tend to miss at least 20 prisms angle many times. That is why we land up many times with the undercorrections. And always, I think symmetrical bimedial recessions or bilateral lateral rectus recessions are preferred rather than doing R and R. And that causes a little bit of palpebral aperture changes. And suppose I think palpebral aperture changes are there. If it's a smaller eye, then tend to do recession in that eye and then go for the resection of the other eye. These are the, and Botox, I think, though I worked with Alan Scott way back in 87, and first to start in India in the 92 on series, I failed miserably. Even I had the EMG machine also. So there were many cases of ptosis and all sorts of problems. Somehow it never worked in my hands. And I'm happy that Shruti is trying it out. And few of my colleagues in Nethralaya are also trying it out. Thank you.
Kavita, just a quick word. I wanted to just add, so occasionally patients will come to you, especially slightly older patients who are, before they want to get married and want to get this strabismus corrected. These patients sometimes will not tell you clearly that they've had surgery. Sometimes they will not know what surgery was done, even if they have. So it's a good idea to routinely examine these patients on slit lamp before you plan surgery to look for any conjunctival scars, so you're not in for any surprises. So just a little tip. Thank you.
Yes, ma'am. It's very true.
Very true.
Yeah, so now we'll go to Dr. Akhila. So she's going to tell us about the science and art of prescribing glasses to children. So Dr. Akhila.
Well, thank you, Kavita. I would like to thank the organizers for giving me this opportunity, and I would like to thank my mentors, because of which I'm here. My topic for the day is on the art of prescribing glasses. Actually, I was having an argument with Kavita on whether it's just an art or a science, the science behind the prescription of glasses. So she still claims that it is just an art. So let's
Not just an art, it's an art.
Oh, it is an art. Okay, I would now agree with the fact that it is an art to prescribe glasses. So
yeah.
Okay. So as a pediatric ophthalmologist, I think everyone should master the art of prescribing glasses, because 80% of the whatever patients you come across in your OPD would probably end up taking a prescription from you. So, but it is not, I mean, it's one of the biggest challenges that you face day in and day out when you think about prescription of glasses in a child. The reason being, I think there is a limited cooperation what you expect from a child, unlike in an adult. And the vision, whatever vision you check in a child who's preverbal is probably not that reliable as you check in an adult. And there is always a risk of amblyopia if you are not to give glasses. So I'm not going to overemphasize the fact that all children, unless otherwise, you need to do a proper cycloplegic refraction, and the cycloplegic drug, what you choose, would depend upon the age and the underlying systemic diseases. Probably you need to take a short history before you jump into the drop what you want to apply and achieve the proper cycloplegia. Now, when you compare children versus adults, there are a few factors which are very different when you are going to prescribe a glass for child. The reason being, the visual needs of a child is very different, and it depends on the age of the child. And you should always remember that these shouldn't have a very strong accommodative element which needs to be taken into consideration before you write your prescription. And always have the thought of the risk of amblyopia. What if in case if you were not to prescribe glasses in this child, would it really induce amblyopia in a child? And you have to have the idea of the basic emmetropization, what the child goes through when the child is born until it reaches an adult. And take into consideration the associated ocular anomalies like a strabismus, which might be secondary to an underlying visual disorder or a refractive disorder. Now, finally, you have to answer two questions. Do you really need to prescribe a glass looking at the retinoscopic value? And if you're going to prescribe, how much are we going to prescribe for this child? So now you have a checklist of questions which you need to answer before you decide on giving a glass to a child. First is you look at the number, you see, is this refractive error within the normal range, for which you need to know the normal refractive errors for the corresponding age. Next is, will this particular child's refractive error emmetropize? Is it well within the normal range where the child would probably become emmetropic with age? And whether this refractive error, if not treated, is it potentially amblyogenic? That is, whether it would disrupt the normal visual development or the functional vision in a child. And next is, will this number, if you're going to prescribe, is this going to improve the visual function of the child, or whether it is going to at least improve the functional vision in a child? And finally, you need to also think of the fact that if you're going to prescribe a number, will it interfere with the emmetropization? Say, for example, if you're giving a full correction in a myope, whether that visual blur is being knocked off, whether that would interfere with the emmetropization of the eye. Now, just a brief thing about the various questions that I have put forth. The first is being, what is the natural refractive error in a child from birth to 3 years? So this birth to 3 years is the, the age group where the maximum amount of emmetropization is going to take place. So as long as, immediately after the child is born, the child is usually hyperopic by +2 with a standard deviation of 2. So this is something which you need to know by heart, and when you're wanting to write the glass prescription. And as the child grows, up to 1 year is the maximum amount of emmetropization what happens, and it continues over a period of time until the child reaches almost 3 years. And even after 3 years, if you see, there is some amount of emmetropization which continues until the child reaches 6 years of age. But the amount of change what happens in this 3 to 6 years is relatively lesser as compared to what happens in the when the child is born until the child reaches 12 months of age. And always remember, there is some amount of significant astigmatism which is present in almost all children up to 1.5. So it does not need any correction. Now, next is, you see a number, you know whether this child is going to emmetropize or not. So it is not a dictum that all children with a +2 or a +3 are going to emmetropize. So this is not true to all children. There are some children who may not emmetropize at all. So how do you predict? There are various factors which help you to predict. And if your predictions are going to be right and you think that this child's number is going to emmetropize, then you can still wait and not prescribe glasses for these children. But if you feel that this number is not going to emmetropize corresponding to that particular age, then you are supposed to prescribe glasses. So now, what are these predictive factors which will help you to take a decision whether to go ahead with the glasses or to wait and watch? One is your level of emmetropia. If the level of emmetropia is going to be really large, then you know for sure that this child is not going to emmetropize, so you better get the glasses. Okay, and then if the visual acuity is going to be really poor, whatever is the type of visual acuity assessment that you can have in a pre-verbal child, if you feel that the visual acuity is going to be lesser than 6/100 or something, then definitely this child's chances of emmetropization is relatively lesser. So you have to give glasses. And the type of astigmatism, whether it is a with the rule astigmatism or if it is a irregular astigmatism, then those children have a lesser chance of emmetropization. And the last is, you have a doubt whether this might emmetropize or not, you can still wait and watch. You call the patient back in 4 to 6 months time and you see if whatever is your expected amount of emmetropization has happened or not. And if it is not happening, then at the next visit, you prescribe glasses. Now, the next is, will this level of whatever is your retinoscopy value, will this disrupt the normal visual development? Otherwise, is this number a potentially amblyogenic refractive error, which needs to be corrected? There are various studies that have been done. The recent, that is the study done by Donahue et al. Is the one which is a modified, which describes the modified amblyogenic risk factors. So any type of uncorrected high refractive error, be it hyperopia, astigmatism, or anisometropia, or myopia during the first few years of life is potentially amblyogenic. I'm just giving you this outline for, it is not age dependent, but if you look at the Donahue's modified amblyogenic risk factors, it gives you exactly according to which age, which number is potentially amblyogenic, and anything beyond that needs refractive correction. Now, will prescribing spectacles improve the visual function or functional vision? You have many studies which have compared children, pre-verbal children who were given glasses and who were allowed to wait and watch. So these studies clearly say it improves the visual function. Visual acuity, strabismus, and amblyopia chances are relatively lesser in children where you prescribe glasses than those children whom you wait and watch. But when it comes to functional vision, there are, apart from acuity of vision, there are other things which also play a role in improving the functional vision, like your environmental influence, your family background. All these things also add to the functional outcome of a child. So in an answer to this, you don't have any quality evidence to state that giving spectacles in these children would probably improve the functional vision, but definitely visual function improves. And now the last question is, will prescribing glasses interfere with the normal process of emmetropization? So this clearly, all studies have shown that refractive correction will influence the development of the refractive error. Emmetropization is a process where there is a complete remodeling of the eyes, and the visual blur is the basic stimulus which drives the emmetropization. So if you're going to block that stimulus for emmetropization by giving a clear image, then it probably inhibits emmetropization. So you should be careful in choosing your numbers when you're prescribing these glasses, because it should not interfere with the remodeling of the eye, what happens in a child. Now, when it comes to children beyond 6 years, it's very easy. You do a refraction, you can probably get a subjective vision check also done with the corrective lenses in place, and this correction is more for function. So you can give the number whatever corresponds to your recorded visual acuity. Now, taking all these things into consideration, you have various guidelines which have been formulated, and the most popular being the preferred practice guidelines, which have been put up by the American Academy of Ophthalmology. And this again is based on a consensus of opinion among the expert panels. So that is the one which we also follow in prescription of the glasses. So this gives you an idea about the type of refractive error, the age, and the amount of myopia, hyperopia, astigmatism, or anisometropia that needs to be corrected. So anything which falls above that needs correction. Now, there are few cases where you don't have to really think twice before you start writing your prescription. That is the absolute indication for glasses. A child who's aphakic or pseudophakic, if there is an anisometropic amblyopia, there is high refractive error and a refractive accommodative esotropia, you don't have to think. Prescriptions would match. Okay, so how much to be correct? There are guidelines for this as well. I mean, depending upon the type of refractive error, if it's a hypermetropia, you look at the retinoscopy value for the corresponding age. If it is more than 95% of the range of refraction, you prescribe leaving behind the mean hyperopia for that particular age. Say, for example, if it is a 1-year-old child, you leave behind what is probably +2 is your normal range. So beyond that, whatever it is, and if it is potentially amblyogenic, the remaining needs to be corrected. And a hyperopia of more than 3.5 diopters in any one meridian in a 1-year-old child and above, you follow the Atkinson's protocol. That is, you give the difference in the sphere and you undercorrect it by +1. And if the hyperopia is more than 2.5 in a 4-year-old, you give the correction, but it has to be a partial correction and you undercorrect it by 1 or 1.5. And anything more than 1.5 diopters in a 6-year-old child, you try to give a full or a near full correction. Now, when it comes to myopia, in a child who's 1 year with a myopia of as much as 5 diopters, you correct it, but you undercorrect it by 2 diopters. And if the myopia is more than 2 diopters in a 1 to 4-year-old child, again, you undercorrect it. You don't give the full correction because you want to maintain that little bit of a visual blur. Okay, and then in a child who is more than has more than 1 diopter of myopia in a 4-year-old child, you can start giving a full correction because this child is again a school-going child. And if the myopia is lesser than 1 diopters in a child who is more than 4 years, and if that can improve the visual acuity, again you go ahead and prescribe the glasses. And anisometropia in a child who is 1 year and above, anything more than 3 diopters, you always try to give the full correction of anisometropia. And if it is more than 1 to 3 in a 1-year-old and above, you always monitor for 6 months. And if it persists, then you can prescribe the glasses. And as far as children who are more than 3.5 years, hyperopia of more than 1 diopters or myopia of more than 2 diopters and astigmatism of more than 1.5 does need correction. And you give the full correction. Now, last is your astigmatism. Astigmatism in a 1-year-old child of more than 2.5, again, you give a partial correction. You don't correct the entire astigmatism because 1.5 is something which is normal. So you give a partial correction. And more than 2 diopters in a 2-year-old and above, less than 4 years, then again, you don't correct the entire astigmatism. You give a partial correction. And full correction would be given if it is more than 1.5 diopters in a child who is more than 4 years of age. And any type of oblique astigmatism of even more than 1 diopter is potentially amblyogenic. So you need to give the full correction again. Now, after thinking and then finally giving a prescription, you review the child in another 4 to 6 months time. And then the mother comes and tells you, my child does not feel comfortable wearing the glasses and he wouldn't wear it. The moment I put it, he just takes it off. So don't try to reinforce this thing. Always go back and recheck your prescription, see if it is accurate or if there is any other optical problem with the lenses, whether the glasses have been manufactured well or if the glasses are not fitting the child well. So always check for all these things, look for any behavioral issues which is interfering with the child wearing the glasses, in which case it might need proper referral. And again, if the change in the, always look for a change in the child's refraction. Some children who probably the aphakic and the pseudophakic children, you might have a myopic shift, which might probably be interfering with the child's glass prescription. And always rule out any other associated problems that would have probably come up in the intermediate period. Now, finally, the tips for prescription. If you have a child who is a one-eyed child and who has amblyopic in one child, always give polycarbonate glasses for protection. And this is a usual, this is a common question. I think most of the parents might probably ask, should I have that UV protection glasses or something? So UV protection glasses you prescribe in children who are aphakic, pseudophakic, or children who have associated maculopathy or on atropine penalization. And again, tinted or photochromatic glasses are recommended in children who have aniridia or albinism. And not to forget the fact that strabismus surgery can affect astigmatism, and these children might have a change in their refraction post-operative period. So always recheck the refraction in children in the post-operative period and change the glasses accordingly. And over-refract in very high refractive errors in order to reduce the errors due to the pantoscopic tilt and the vertex distance. Thank you.
Thank you so much. So is it an art or a science? You didn't tell.
I would agree, it is an art.
Yeah.
But there is science behind it still.
So it's one of the most challenging things for all pediatric ophthalmologists is to prescribe glasses, even though it sounds very easy. It's like in an adult, you can't just do an autoref, refraction and take a printout and hand it over. So all this that Akila has now summarized, all this thing goes into prescribing glasses. I think it's very clear. There's really nothing to contradict or add. So any panelists, any addition to what Akila has said?
Just to confirm, after I think writing the prescription, the plus and minus sign sometimes I think can misfire. It has happened few occasions, even in my case. So I think our mentor, Dr. Badranath's, this thing was in early late 70s was to that we need to reimburse that amount to the patient. That is how he trained us. If you write instead of plus a minus, or instead of minus a plus, or even in astigmatism, this actually, once I paid, and then after that I'm very careful to recheck again and again. Just to take.
The only thing I tell parents, especially of very young kids, who are sometimes hesitant to buy glasses from you. So I always tell them, go to a big store because you need child frames and have the frames flexible and colorful. But more importantly, they'll come and tell you, so I always tell them at the beginning itself, fund fund. So just accept that when for a child, the breaking the glass or being a little rough with the glass is part and parcel of growing up. But at the same time, you teach them good discipline. Tell them how to take off the glass, how to put the glass. You as a parent take the glass and put it on the table and see that both temples, both the things are touching equally. There is one is not tilted like this. Inspect your child's nose to see if there is a pressure on one side and there is a mark, which means the nose pad has come off or the glasses are crooked. These are all things you can do as a parent. This is something I tell the parents, every parent.
Yes, ma'am. Thank you so much. Now I invite Dr. Muralidhar from Eye Foundation to talk about nystagmus. Let's make it simple. Let's see how he makes it simple for us.
Sincerely thank the Tnoa Scientific Committee, my good friends Kavita and Jayantan, for having invited me for this wonderful talk. And it's been a rich learning experience, and it is very nostalgic to be with the SN Dream Team again. So can you see my slides?
Yes. Yes, ma'am.
Okay, thank you so much. So in all these meetings, I have always been asked as to what are the telltale signs or red flags in nystagmus. So I thought I would start not with infantile nystagmus syndrome as I usually do, but I would start with some of the telltale and localizing signs. So this was I have taken photo consent for almost all patients in this presentation, but nevertheless tried to hide their identity to the maximum extent possible, except when it is. Yeah, so this patient presented with a head nodding, was already diagnosed by the neurologist. So when the head nodding was controlled, this patient develops a fine. Yes, sir.
Put slideshow.
It is in slideshow only, sir.
No, sir, we can't see.
Slideshow is not visible.
You are able to see my slides?
No, it's not on slideshow.
It's not on slideshow, Murli. It's on.
Yeah, is it visible now? As a slideshow?
Yes, now perfect. Yeah.
Yeah. So apologies for the delay. And so this patient was referred to me by a neurologist, and he had his suspicion, so he had referred it to me. So note the head nodding in this 1.5-year-old. So when you control the head nodding, you can see the nystagmus. And parents were very concerned. And this is the photograph of, this is the video of the child when the child is a little older, around 5-6 years of age. The head nodding is gone. So this was a very classic patient with spasmus mutant. We had gone, the MRI was already done by the neurologist. The neurologist had also diagnosed it as spasmus mutans and just sent it across for confirmation. So note the head nodding. When you control the head nodding, the nystagmus appears. So here, unlike in congenital nystagmus, the head nodding is compensatory for the nystagmus. Typically, the nystagmus is fine and asymmetric, but all clinical features need not be present in every patient. So this patient was referred with oscillopsia, and note this. So these are eyes that shake at will, but typically the patient will not be able to sustain it for more than a minute. So now the nystagmus is not there. When you ask her to start again, she can start the nystagmus on her own will. No further workup is needed. This is a typical patient with voluntary nystagmus. So no further workup is needed. And this is another classic patient who had bitemporal hemianopia on fields, also had this finding. This is a seesaw nystagmus. One eye rises and intorts, the other eye falls and extorts. And this patient had a huge pituitary adenoma, which was extending suprasellar and parasellar also. This is another very alarming feature that we should all watch out for. This is a patient with a convergence retraction nystagmus. When the patient looks up, you can also use an OKN drum to demonstrate. Not typically a nystagmus, but this is a classic sign in Parinod's dorsal midbrain syndrome. And this patient had a malignant glioma, which showed up on, ideally an MRI should have been done. A CT was done for costries. So this was another movement that was recorded on slit lamp. So this patient again was referred by a neurologist who had made the diagnosis of a brainstem stroke. And before MRI had sent it to us. So this is a very classic patient with dorsipulsion. This is again not nystagmus. Nevertheless, in this presentation, because I wanted to show the red flag signs first, this is a classic patient with dorsipulsion. And we made a diagnosis of Wallenberg syndrome, which is posterior inferior cerebellar artery infarction. And a saccade brings about this movement. That is very classic about this. But the patient typically does not complain that the world around him is torting. The patient is asymptomatic as far as this torsional movement is concerned. Many times they'll have vague complaints of the room around them being tilted. Sometimes they are dismissed as psychiatric. I was fortunate because the neurologist had referred. Then we got an MRI done, and this showed a posterolateral medullary infarction because of a PICA infarct, posterior inferior cerebellar artery infarct. So now note this patient with a left 7th nerve palsy. He also had mild blurring of the disc margins and increasing esotropia to the left. I didn't put that video because the aim was to show the Bruns nystagmus. So note this, on looking to the left, he has a large amplitude, low frequency nystagmus. And when you ask him to look to the right, he has a low amplitude, high frequency nystagmus. He also had a corneal hyposthesia. Typical textbook diagnosis of a cerebellopontine angle tumor. So this patient also had an obstructive hydrocephalus because of a cerebellopontine angle tumor. He underwent a decompression and excision of this CP angle tumor with complete resolution of ataxia, papilledema, and 6th nerve palsy. So that is what is important. This patient had a closed head injury in a road traffic accident. This again is not typically a nystagmus, but note the nystagmus in the abducting eye. The adduction is restricted because the adduction restriction is so subtle. The sparing of convergence is not very obvious in this patient. We made a diagnosis of a traumatic internuclear ophthalmoplegia, and you can see this infarction. This is the floor of the 4th ventricle. This is the ponto midbrain pontomesencephalic junction, and this is the pons. The floor of the 4th ventricle. You can see a hyperintensity here. He responded very well to steroids with complete resolution. And this was again referred to me by a neurologist. This again is not a typical nystagmus. So note this dizzy eye movement. So note this dizzy eye movement. You see predominantly vertical. The important thing here is that the defoveating movement is a saccade. In a nystagmus, the defoveating movement is a slow eye movement. So usually they are, I mean, primarily vertical flutters, but occasional oblique and horizontal also. There is no intersaccadic intervals. So oncology workup was negative. So this is a patient with opsoclonus myoclonus syndrome, and he was started on oral steroids and clobazam, and had the partial resolution of that, partial recurrence after stopping steroid, and continues to be on our follow-up. So this was a patient, one of our camp patients who was referred because the patient had mature cataract and squint, and this is a Heman-Bilshofsky phenomenon, slow upward and downward movement in eyes with poor vision. Sometimes these patients can develop oscillopsia in the postoperative period. So now we come to the actual definition of nystagmus, which is a regular rhythmic to and fro oscillatory movements of the eyeball. Usually it is involuntary. And the important thing here is that the defoveating movement is a slow eye movement. Like in ocular flutter and opsoclonus, the defoveating movement is a saccade, and typically there is no intersaccadic interval. Here, the defoveating movement is a slow movement. You don't, I mean, it's good if you have eye recording. I mean, that's the best thing to have. We don't have. But clinically also, you should be able to make out that the defoveating movement is a slow eye. So congenital vis-a-vis acquired, history plays a very important role. Congenital, never seen at, it's not congenital essentially, it's infantile nystagmus syndrome. And typically never at birth. Usually onset is between 2 to 6 months of life. The presence of oscillopsia signals that it is an acquired nystagmus, not always. Sometimes congenital nystagmus patients, when there is change in lighting conditions, or in patients with cone rod dystrophy, when the vision drops, sometimes they can have oscillopsia, but oscillopsia typically is a marker for acquired nystagmus. Associated neurological features also would favor a diagnosis of acquired nystagmus. So now coming to the nystagmus workup. So if, you need to divide it into these three categories. I borrowed this, I borrowed and modified it from mrcoff.com. I found it very useful for my clinical practice. The classification into congenital motor and congenital sensory, even though theoretically it is not valid, it is of good practical use. So if nystagmus is manifest in primary position, if the vision is better than 618 or better, the best corrected visual acuity, once again, I would say that binocular visual acuity and fogging, I'll be coming to that in the slides to come. If vision is better than 618, then possibly it's a motor nystagmus or an infantile nystagmus syndrome. If the vision is less than 618, you need to look for a sensory cause. If it is evoked by eye movement only, then for binocular nystagmus, you have these possibilities. For monocular, it's internuclear ophthalmoplegia. If it is manifest only on cover, then it is latent and you need to exercise special care in vision test. So that is just to emphasize that. And now this patient has, I mean, the diagnosis is very obvious because that is the father and this is the child. So this child, quite fair and has a sensory nystagmus. So a classic diagnosis of an oculocutaneous albinism. So child had poor vision, so had also foveal hypoplasia. So the vision, best corrected vision is less than 618. Of course, in this child, we used Lee-Paddles to test. But if the vision is less than 618, then you need to look for a sensory cause. In this patient, it was obvious. So you can see the cataract here, one eye operated, the other eye to be operated. It was a neglected cataract. I mean, sometimes we do see these neglected cataracts, and the nystagmus is sensory in origin. Okay, nystagmus is sensory in origin. She needs cataract surgery with low vision rehabilitation. So sometimes the fundus is normal, and history of consanguinity, which is rampant in South India, helps, and history of night blindness also. And this child was has a pendular nystagmus, and the ERG is a flat recording. So this patient had a Leber's congenital amaurosis, or an early onset cone rod dystrophy, as we typically call it. So
the astute clinician should be able to pick up fine nystagmus as seen in this patient. An ERG shows a cone rod dystrophy.
Is the asymmetric nystagmus.
The clinician should be able to pick up fine nystagmus as seen in this patient. An ERG shows a cone rod dystrophy.
We need to rule out these cone rod dystrophies and also disorders of the optic nerve and chiasm. So this patient had night blindness since, for a very long time. So we got this done. Many times the fundus is normal in these cone rod dystrophies as well as Leber's congenital amaurosis. So we need to fall back on other, on the clinical history of consanguinity, history of day-night blindness, and history of ocular digital sign, and also paradoxical pupillary dilatation in light. All this helps when the fundus is normal, and then of course we get an ERG done after the first year of life. So infantile nystagmus syndrome is characterized by a head posture typically, and sometimes they don't have a presence of a null zone, which is an obvious corollary. and it is increased by, accentuated by fixation, or when the patient is very tense, dampened by convergence, which means the nystagmus is less for near, distinctive waveforms when you have eye movement recordings, and horizontal across all gazes. And typically it is symmetric and conjugate. Conjugate meaning beating in the same direction, and symmetric means both eyes have the same amplitude and velocity. So this was again a very typical listing referred for poor vision. So this patient has a large amplitude, manifest latent nystagmus. That term is now given up, and fusion maldevelopment nystagmus is what is the new term by the CMAS classification. So special consideration is needed in vision testing for these patients. Binocular vision testing, or you can fog one of these eyes for binocular vision testing. Now, the principles of infantile nystagmus surgery for infantile nystagmus surgery is that you mechanically, there are two principles. One is you move the null zone to coincide with the primary position, or you can fall on the Hotel Delosso principle of broadening the null zone. So we need to note here that the head posture needs to be confirmed. I typically operate them around, after 5 or 6 years of age, preferably, having taken care of the refractive error, the amblyopia, and having confirmed the head posture on at least 2 occasions of 8 minutes observation period each. Keep on changing the targets, at least 8-minute observation period on at least 2 or more occasions. So this was a typical patient. So I follow very simple principles of surgery. I would just describe. The principle is the same. You move the eyes towards the null zone. So this is the pre-op. When you correct the head posture, this patient had almost 35 degrees of head posture. And you note this. So here you need to bring out, this is the postoperative after plication augmentation of the augmented Anderson procedure. So till 20-25 degree, you can do the augmented Anderson procedure. And beyond that, I usually add a plication augmentation. So the key thing here is to bring out the maximum. This is the postoperative picture. The key thing here is to bring out the maximum head posture. I'll just describe in the slides to come. So note this patient with a large left head posture, again 30 to 35 degrees. So many times they don't bring out unless you force them to bring out the maximum posture. So when you correct the head posture, so you see the nystagmus. So when you increase the head posture, so there is no head posture for near. So this is after plication augmentation of the augmented Anderson procedure. So the patient doesn't have any head posture. The nystagmus in primary position is better. And even after plication augmentation, the movement restriction is to the order of 1- or so. So this is another patient with the plication augmentation of the augmented Anderson's procedure. This is the preoperative head posture, and this is the postoperative head posture. So now coming to how to bring about the maximum head posture. So this patient has a chin elevation. So you need to move the eyes down. So when you correct the head posture, you see that the nystagmus is elicited. For near also she has. So we follow 3 principles in bringing forth the maximum head posture. So we keep on adding prisms, same strength in the direction of the gaze until there is a small reversal of the head posture. And the surgery is typically planned for around 10% more than the prism strength that we get. So this is what we did for her. And this was the preoperative head posture. This is the postoperative head posture. So small initial overcorrection is desirable. So these are the 3 principles that we follow. One is the forced best corrected visual acuity. That is, we get the child or the patient to read at least 2 lines below what is a best corrected visual acuity. And second is reversal of fast phase. So reversal of fast phase happens across the null zone. And so that is taken as an indication of the null zone. Many times these patients may be very shy and they may accept a little bit of nystagmus, and just for social reasons, they may not assume the full extent of the head posture. So many publications are there which have reported very good correction with very small doses of nystagmus surgery. So this can be avoided if you elicit the forced best corrected visual acuity. Consistently ask the patient to read 2 lines below the best corrected visual acuity that is recorded. Look for reversal of fast phase. And as I showed in the video, prisms to just reverse the head posture. So all these 3 would, we should not be afraid to do this in the postoperative period. So nystagmus undercorrections can happen. I mean, it's better to accept that rather than, underreport this. So when you have a complex head posture, when you have a combination of head posture, like this patient has a chin elevation, has a right face turn, also has a head tilt. So try to correct the biggest head posture, biggest contributor. So we corrected the horizontal head posture by an augmented Anderson procedure and managed to get a fair correction. She does have a little bit of residual, but managed to get a fair correction. So now this is a challenging combination. So as I said, many times these patients may not assume the full extent of head posture. They may accept a little bit of nystagmus. They won't assume the full. So this patient also has a manifest latent nystagmus. So in this case, if you tip the head posture towards one side, so this patient has an exo also along with that. So when you tip, note that in this head posture, in this position, the patient doesn't have nystagmus. So the patient has a null in adduction along with exotropia. So that's a goniometer being used to measure the head posture. So this is a null in adduction with exotropia. It's a difficult combination to correct. What we did was we did a large LR recession on both sides, bilateral lateral rectus recession with Faden on the medial right. And yeah, I mean, managed to get a good correction of the exotropia. So this is the catch here. So note that the patient is still not adopting the head posture, even though there is a small nystagmus. So if you cover one eye, you can get, you can elicit the nystagmus. See, there is still a head posture. Okay, it's better than what it was before. So better not to, be, I mean, this is the best, this is possibly the best that we could have done. So anything else would have messed up the strabismus. So that's it. And this is a patient that I had the opportunity to manage with Jayantan.
A 12-year-old boy presented to us with
So it was
complaints of right face
Jayantan
turns
and I
since
managed
early
it
childhood.
when we were in Arvind.
Examination showed 30 degrees right face turn with chin elevation with fixation preference for the right eye. Correcting a face turn revealed large amplitude pendular nystagmus and left esotropia. He underwent surgery on right eye. On first postoperative day, he was noted
So the
to
face
have
turn
a
switched
large left
because
face
of a
turn
fixation switch.
with a small exotropia and fixation preference for the left eye. The patient was reassured and requested to come 2 weeks later. After 2 weeks, he showed a small right face turn of around 5 degrees with chin elevation and head nodding. There is a consecutive exotropia of around 12 prism diopters and the nystagmus amplitude
So this was
has
his
reduced.
journey to getting partially relieved. There was a fixation switch, likely because of irritation by the sutures. We also gave him a comprehensive opthal examination just to make sure there's nothing amiss in the fundus. There was no RAPD or anything. So he spontaneously went back to, his fixing with the right eye. And I think, thank you so much. It was an honor to participate in this. So I will just stop sharing and.
Wow, those were amazing collection of videos and patients, Murli. That's such a variety of nystagmus. And my only question is, what is your long-term, a lot of surgeries you're doing for AHP and all that. What is the long-term effect of the surgeries? Like, do they last?
That's a very pertinent question, Kavita. So the long-term, three things could happen. Generally, what I have seen is that they usually have a small residual head posture. That is the best outcome that you could hope for. Sometimes what happens is they develop a new head posture, that is a head tilt or a chin elevation, which happens in a small proportion of patients. But by and large, what we see is that a recurrence of head posture or a small residual head posture, that is the best outcome that you could hope for. I would say on a conservative estimate, almost 80% of them we are able to give a very good outcome. Having said that, nystagmus is a very, very unforgiving surgery. So in case there is a mess, I mean, it's a real mess. So I have to have a careful preoperative assessment, and always we need to leave the field open for a second surgery. So in case we need to resect it, I would prefer to do plication, taking care to spare acute ciliary vessels, to allow for reversibility in case you have missed a periodic alternating nystagmus, or to operate on a third, to leave the option open for operation, surgery on a third muscle, should that be required in future. So I would say on a conservative estimate, 80%, yes, acceptable head posture in my follow-up of around 5 to 6 years. That is the longest follow-up that I've had for these patients. And yeah, I mean, having said that, nystagmus definitely is an unforgiving surgery. So if a mess happens, it's a big mess.
Right. Thank you so much. And
any approach for head nodding, because a lot of patients complain of head nodding, and somehow the traditional surgeries don't seem to relieve that too much,
yes,
even TNR. So you have anything to add on that, or anybody in the panel can add?
I don't
Sometimes
have,
patients
madam.
come
I
not
wish
so
I
much
had.
for nystagmus, but because of the head nodding, which is quite disturbing for the.
I did try brinzolamide for a couple of patients, madam. Didn't work out, so I
Did
don't
not
have
work.
an option. Yeah, I don't have
Okay,
So,
thank you so much, Murali. Now I invite Sumita ma'am to tell us different now away from strabismus, we come to cataract surgery, the management after you do the surgery. So that's very important. So let's hear her tell us what to do.
So this is the topic which has been given to me, and honestly, when we look at the perspective of a long road following surgery, I operated on the father when he was a teenager, and now I have operated on his daughter also. So, and both of them are still my patients. So that just gives a perspective of how long they are going to be in your care, despite good surgery. So let's face the facts that most of these children will need glasses following surgery, and a lot of times clinicians do, despite doing a very good surgery, sometimes miss out on this small part of the management, and this should begin as early as possible, and sometimes it can be done even as early as third postoperative day, and glasses can be prescribed, especially in aphakics. You don't have to wait for 4 weeks and 3 weeks. You can do a dry refraction and give the glasses in children who are infants and in whom you have not placed IUL. Sometimes people hesitate to give glasses because there are high cylindrical powers because of the sutures which you have placed. But a lot of these tend to get, cylinders do tend to disappear very quickly, and you can definitely prescribe at the end of a week the glasses. Older children, you should always prescribe a reading aid or a progressive addition lenses because they do need both near and distance acuities. And this part is also sometimes missed. In very young children, you can give near correction, appropriately near correction, even if you have placed IUL, or you can give for an intermediate. So let's say if your refraction has come around +4, you can give them +5.5, which gives them fairly good near correction as well as distance correction. Instead of giving bifocals, and bifocals you can prescribe them when they are starting school or when they are 3 years or so. So when it comes to aphakia, as I said, these are our options. You can always use glasses, contact lenses, or intraocular lenses as your rehabilitative method. So glasses work very well for bilateral aphakics, though it can be heavy. It's important to have a good frame with a good nose support. These induced magnification and chromatic aberrations, ring scotomas, and all the other aberrations, optical aberrations which are produced, do drop quality of vision. But in our population, probably if it's a bilateral aphakia, aphakic glasses are fairly good chances, fairly good option, and most easy to manage for the parents. As I said, here is a example of a badly fitting frame. You can see the nose clip is very thin, and here is an example of a good fitting frame, and you can see the children are using the glasses much better when the frame fits better. So a larger clip which supports the nose is very, very important if you're going to give a very thick, heavy glass like aphakic correction. Mothers being mothers will always come up with some innovative solutions for this, and I'm really happy with this mother who has come up with some clip which holds the glasses always in the visual axis, and child is perfectly happy using it despite glass being not of very good quality, as I would say. Contact lenses, again, expenses, management, replacement are always an issue. And you can have an option of RGP and soft lenses. RGPs are kinder on the eye and pocket, but can have high lens loss rate and tolerance issues, especially when the children who grow up into toddlers. Then it becomes difficult to put them, maintain them, and they tend to lose it also far more frequently. However, if it comes to quality of vision, several studies have proved that both IOLs and contact lenses provide equal quality of vision. And if you are not very comfortable with putting an intraocular lens in a child, you should definitely look at contact lenses as an option with a little bit of training to the parents to take it out regarding the care. Now coming to amblyopia, again, this needs to be managed post-surgery. And the risk factors of amblyopia following cataract surgery are delayed diagnosis and surgery, very common in our country because they don't come to us in fairly early ages. Some asymmetrical or unilateral cataract, again, very important risk factor for developing amblyopia in these children. Associated strabismus is also a risk factor. And if there is an nystagmus along with cataract, again, which also shows delayed diagnosis, can often lead to poor, these children are most likely to have amblyopia and poor vision despite good surgery. So in these cases, as I said, your options of management here are patching, you can do penalization, dicoptic, and perceptual learning. And as I said earlier when Dr. Meenakshi was giving her talk, several of them have not really been studied in deprivational amblyopia, and in unilateral cataract, goals must be realistic and discussed with parents. Here I would like to just make a small point. In unilateral cataract, sometimes vision is 3/60 with glasses, 3/60 without glasses, or 1/60 or even less. And sometimes clinicians don't give glasses saying that vision is not improving. But I think refractive correction must be given even if it does not show improvement with glasses. And patching can be part-time or more aggressive depending on how much vision improvement you have got with surgery. Start early and aggressively, but do not give up too early on patching in these patients, even though your goals of your improvement in unilateral or asymmetrical cataracts are more realistic than say children who have done well with intraocular lens. Again, as a part of follow-up, what may need intervention in these children: visual axis opacification, secondary glaucoma, strabismus, sorry for the spelling mistake there, and retinal detachment. These are all long-term things which you have to look at the patients following cataract surgery. And most common is visual axis opacification, which can undo your beautifully done surgery within few weeks and can lead to a vision drop almost instantly. In younger the children, worst is the vision, role on the vision. So there is role of primary posterior capsulotomy, and those who do frequently, children more frequently in their practice, often add this small step at the time of surgery. And it should probably be a part of surgery in children who are less than 6 years of age. And it definitely ensures a fairly long clear visual axis. And you can combine it with anterior vitrectomy or pupillary capture depending on your surgical ease and expertise. And probably anterior vitrectomy may not be required in children who are older, and you can just get away with just doing a primary posterior capsulotomy. However, you must consider primary posterior capsulotomy even in older children if they have intellectual disability, if they have a really coarse nystagmus, or they have uveitis related cataract, traumatic cataracts, because these are very difficult to open. These capsular opacifications are very difficult to open using a YAG laser. Often they are fibrotic and thick, and very difficult to, you have to use sometimes large amount of energy with pitting, risk of pitting, to open these capsules if you are using laser. So if you see these kind of factors, it's probably a good idea to do a primary posterior capsulotomy. For rest, you can do a laser. Older children, very easy to do it. It can be occasionally done under GA also, and we have done it. However, as I mentioned earlier, it's difficult in thick fibrous capsules. And here also trick is to always start with the lower energy and increase as you gradually. You have to warn the parents that this may have to be done more than once. And of course, technique has to be defined so that IOL pitting is minimum. Sometimes these are really thick and you have to use a membranectomy for these. And this is one of the most common indications for resurgery in children, and more so if the children have been operated when they are really young. Failed laser also can be an indication for membranectomy, and both limbal and pars plana routes can be used depending on the position of the lens. If the lens is in sulcus, you can use a limbal route more comfortably, but if the lens is really snugly in the bag, pars plana route is probably more easier to do. Occasionally, there may be anterior capsular fibrosis or phimosis, which can obscure visual axis, and that also may need a surgery to improve the visual axis clarity. Now coming to strabismus, it is strongly associated with pediatric cataracts and can be pre-existing and can develop after cataract surgery. It is also one of the commonest indication for a second surgery in these children, and presence of strabismus can add to the visual impairment, so that factor must be kept in mind. It definitely interferes with good binocular vision post-cataract surgery if it is present. So why strabismus happens? Because of the disruption of the binocular, sensory and motor fusion, leading to the loss of alignment. Sometimes aphakic correction can cause a significant anisometropia and anisoconia, especially in unilateral cataracts, and that can lead to strabismus. Sometimes deprivation, and in bilateral cataract, if there is unequal vision post surgery, then also there may be a strabismus. So these are the risk factors for developing strabismus following cataract surgery in children. A lot of times it can be a useful tool for a preoperative evaluation, because strabismus is often indicates that visual cataract is visually significant, and it's an important diagnostic tool. Like this child who was referred to the hospital only because of this squint, and did undergo surgery for the cataract, and cataract was picked up because of the squint. When to plan, there is probably the principle is same, that you do as far as possible try to achieve the equal vision or a full trial of amblyopia therapy and visual rehabs. Younger children, probably you should wait till you have reliable measurements. However, do offer early surgery if visual outcomes are good following surgery, and delay surgery if there is amblyopia or very, very poor vision following cataract surgery. And also in special children, probably it's a good idea to delay strabismus surgery a bit. Sometimes cataract surgery itself can improve alignment. So measurements are something similar, and I won't go into details here. But a lot of these children can have head turns and all abnormal head postures which are related to nystagmus, and that should be factored in when you are planning, do surgical planning for these children. So like as I said earlier, sometimes correcting the surgery itself can improve the strabismus. As this child, he's here pre-surgery and post-surgery with glasses, as you can see, alignment is better. So horizontal is more common. You can, during surgery, probably fornix incision is preferable over limbus, because you don't want to use, you want to use the least amount of conjunctival dissection. Again, hooking and dissection should be careful. Surgical dose will depend on measurements. And if there is indeed a head posture or a along with nystagmus, that surgical plan should address that also. And of course, as Murli said earlier, counseling for resurgery should be done if the vision, especially if vision is very poor. Doing it together, not recommended, or not really my choice of doing it. In younger children, probably as visual outcomes are not certain, it's probably not a great idea to do squint and cataract surgery together. But in older children, where you know more or less how much vision child is likely to get, both the procedures can be planned together in certain situations. So glaucoma, again, this needs a follow-up, and this is one of the most common reasons for. Now, important thing here to remember is that congenital glaucoma, like this child, large eyes, ophthalmology, is easy to pick up and is almost never missed, and often gets very early intervention. But a phakic or a pseudophakic patient where eye looks nearly normal, there is no enlargement, you can miss glaucoma easily, and can go on missing it for years before there is advanced loss and optic nerve damage. So incidence can vary from 10 to 100% depending on how long is your follow-up. Risk factors are at young age at the time of surgery. Microphthalmos and microcornea is also a risk factor, and cataract secondary to intrauterine infections also may lead to some amount of risk factor to the glaucoma post-surgery. Intraocular pressure must be an integral part of every follow-up. However, we are now lucky to have newer tonometers which may have made the IOP check easier even in younger children without anesthesia with fairly reliable readings. Older children are usually cooperative for applanation tension, and you should probably use AET only in those. Important to note the red flags for glaucoma, which are myopic shift, disc changes and loss of corneal luster or haze, especially when you're comparing both the eyes, are important red flags for picking up glaucoma. So these are the two tonometers which are commonly used. Eye care, which can be used in younger children without anesthesia, has really revolutionized the way you check the pressures. And of course, Perkins is gold standard when it comes to children because it gives you applanation readings and is far more reliable than any other equipment. So management, again, unlike congenital glaucoma, medical management works well. It's important to start with 1 drop and then add instead of adding 3 drops at the same time. And probably beta blockers and aqueous suppressants are usually the first line of medication. And then depending on pressure control, you can add another drops. Advanced cases, of course, will need surgery, and that is beyond the purview of this talk here. Thank you for your attention. So usually if you manage these patients well, there is no time limit when you can say, okay, after this, you don't need to see me. And this needs to go on throughout the lifetime. Thank you.
Very good.
Thank you so much, ma'am, for covering so much in such a short time. So we can't reiterate, I mean, we can't say that it's more important that cataract surgery management actually is lifelong. So we'll go to the last talk, which is very relevant for all pediatric ophthalmologists when we see red eyes in children. So how do you go about red eye management in children? So I invite Dr. Anthony, please.
Good afternoon, one and all. It's a great honor and privilege to be amidst so many stalwarts to speak on this topic of ocular allergy and red eye in children. I first of all thank Tnoa and Shankar Nethalaya for having me here. So this is a patient whom I came across, a 25-year-old male with history of defective vision worsening for the last 6 months. On examination, he had bilateral posterior subcapsular cataract, and on probing, we found out that he was using diphenhydramine eye drops prescribed elsewhere for allergic conjunctivitis a year back, and he has been using those drops for a year. Luckily, his intraocular pressures were normal, but he had started developing bilateral cataract. And when we found that this cataract was no way decreasing even after stopping the drop and it was progressing, then we had to go for cataract surgery in both his eyes. This is another kid who is 8 years old, came to us with allergic conjunctivitis and papillae and muddy conjunctiva and everything, but on examining the cornea, we found features which are suggestive of keratoconus corneal ectasia. You can see the keratoscopy pictures also. So she had keratoconus secondary to recurrent eye rubbing because of allergic conjunctivitis. So that, all this brings us to the point as why knowing about ocular allergy is very important. About 10 to 20% of the world's population have ocular allergy. Actually, when I looked at this data, I was surprised. 20% of the world's population have had ocular allergy one time or the other. And the prevalence is actually all over the world, it's rising. One interesting thing which I noted is a few decades back, the allergic conjunctivitis was more seen in developed countries, and in developing countries it was very less. But now the chiasm is matching up, and the prevalence is increasing even in the developing countries. And if 100 children walk into your clinic, and children adolescents, about 10 to 12 of them will be having allergy. And in the first case, as I told you, being underdiagnosed, undertreated, using self-medications, over-the-counter medications, or abusing medications which are prescribed for a short period of time, for a long period. So all this and the consecutive side effects which they face, all this brings us to this one that, it's a very important topic. Basically, so some basic things which we all know, it is divided into acute and chronic. I'm going to talk more about chronic vernal keratoconjunctivitis because atopic is more in adults, and giant papillary conjunctivitis is a microtraumatic disorder. So we'll be talking about vernal keratoconjunctivitis more. So you all know that it's mostly a type 1 hypersensitivity reaction, but now they found it, it is also known that type 4 also plays a role, and environmental factors, the genetic factors, the neurological factors, hormonal factors all play a role in PKC. And this particular group, they have really told that since we all know this allergy conjunctivitis is a perversion of the anti-parasitic immunity. They say that the increased prevalence of allergy is also related to increased deworming. I don't know how far it's true, but they are suspecting it. So itching is a very important symptom that we all see, and there's no itching, there's no allergic conjunctivitis. So that's the dictum. And when there's light sensitivity as a symptom, then we should think that it could probably be the involvement of cornea. So this is a graph which shows actually it is taken from LVP study, which is a big data study analyzing lakhs of children and adolescents with allergic conjunctivitis. So you can see that the prevalence is more in the pubertal age group, and in the prepubertal age group, it is more in the males than in the females. So these are all normal, well-known findings that you get the cloudy thickening, then the papillae, then the giant papillae, which becomes cobblestones, scarring, fibrin deposition on the giant papillae, and in the limbus you have gelatinous limbal thickening, horned Ranta's dots, which are composed of eosinophilic and epithelial debris. When it comes to the cornea, you get micropannas, your pernicious epithelopathy, or there's reticular pattern SPKs. Then you worst cases you get shield ulcer and vernal gerontopathy. So in the study, this data study, they found that most commonly we find papillae in patients with allergic conjunctivitis, and we also see that they coexistently they may have blepharitis, chalazion style, all because of this finger eye contact they have because of allergy. And this perilimbar thickening and congestion are quite common. This multi-appearing conjunctiva pigmentation can be there even after the allergy subsides. It is going to be there for some people. And cornea is clear in most of the patients, but SPKs are also quite common. So the complications that we are worried about in patients with allergic conjunctivitis is like shield ulcer. This is the case of perforated shield ulcer, which is managed with keratoplasty, keratoconus, dry eyes, limbal stem cell deficiency, lid complications because of recurrent rubbing, cataract and glaucoma because of adverse side effects of medication. What are the causes of visual impairment as such? Why do people with children with allergic conjunctivitis have low vision? So visual impairment could be, most of the cases, it's because of keratoconus and cataract developing, or a corneal scar, or uncorrected refractive error and amblyopia together. So these are different causes for which cause visual impairment in children and adolescents with allergic conjunctivitis. So sometimes objectively grading the patients is very important, especially when you want to do a study or you want to really see how far the patient has improved with your medication. So there are different grading systems: the Bonini grading, Dicoptic grading, and the 555 grading. So I have the references below. So Bonini grading actually grades as grade 0, 1, 2A, 2B, 3, 4, and 5. One good thing is, they have mild, intermittent, moderate, intermittent, and moderate persistence. So not only the clinical signs, but the temporal nature of the clinical features are also given importance to the classification. Depending on all these characters, they are grading the allergic conjunctivitis. Similarly, Dicoptic grading also is somewhat similar, but the more clinical features are taken into account in the Dicoptic grading. One good thing about these two grading is that they also give a framework of how you should go about with the treatment given the stage of allergy. So when we talk about management in ocular allergy, the main thing is prevention. So we always tell our parents that you have to find what the allergen could be and suspect allergens, and try to avoid them as much as possible. And parent education, I feel, is very, very important in treating patients with allergic conjunctivitis, because doctor shopping is very common in patients with allergy, because they think that once they use the medicine, it should go away. But it doesn't go away. So once they stop the medicines, after some time, it's going to recur. So telling the patient, teaching them about this disease, and teaching the parents about using the medications for the right prescribed time is very important. And most of the time, we can manage most of these patients moderate allergies with topical medications as such. Lubricants help in washing away the allergens, so they play an important role. And simple antihistamines or muscle stabilizers like sodium chromoglycate or dual action agents like olopatadine, bepratostatin, alkaftitin, or isolastin, all this can be used. Non-steroidal anti-inflammatory agents like ketorolac also play a role, but they sometimes NSAID drops can have their own corneal epithelial toxicity, so they must be used with caution. Low potency steroids like chloromethylene acetonate and loteprednol should be the first line of management when you see patients with moderate to severe allergy, rather than going for high potency steroids in the first place. In patients with recalcitrant and recurrent allergies, we can always go for immunosuppressants like tacrolimus, cyclosporin. Tacrolimus low strength is also available, which works quite well. And you also see that in olopatadine, you have higher doses like olopatadine 0.2 and olopatadine 0.7%, which are quite good in managing patients, in controlling the allergy. One thing that I practice and many senior consultants also tell us that when we start patients on medications, we should start them on low-dose steroid to alleviate the symptoms and signs at present, and coexistently start them on a muscle stabilizer so that the recurrence is prevented. If we start them only on low-dose steroid, after some time it's going to come. And putting them on this dual action agents for quite some time actually helps to control the allergy to a good extent. Supratarsal injection is reserved for severe cases with shield ulcer on very bad cobblestone pathway. So this is the Bonini grading, which shows. Actually, I have put this just to show that we cannot in mild patients. It is no point in starting steroids immediately, nor putting patients on severe allergy with only anti-allergic topical muscle stabilizers like that. So judicious use of steroids is very important in managing allergic conjunctivitis. So all allergy is not allergy. So there are other differential diagnoses, when we see of for red eye in children. So things like corneal ulcer could be there, anterior granuloma. This child is a child who came to us after taking bath with custard apple powder, having toxic keratitis, custard apple keratitis, and foreign body in the conjunctiva. So something very important that we should always look out for children with red eyes and eye discomfort, especially when the cornea is not looking very healthy. Always we should avert and look for a foreign body in children. So it could be infectious, like it could be infectious involvement of the conjunctiva or the cornea due to viral, bacterial, parasitic causes, fungal causes, and ocular surface disorders like blepharitis, dry eyes, especially nowadays, which is more on the rise in children, dactylocystitis, inflammatory causes like uveitis, episcleritis, and trauma are causing as simple as succumbing hemorrhage to as bad as a penetrating eye injury. Foreign bodies especially should not be missed as I told before. Chemical injuries, others like congenital glaucoma, we should always keep in mind. So my talk here, my aim was not to be exhaustive in this one, but I just wanted to tell what we routinely clinically do and what are the important clinical differential diagnosis, the common differential diagnosis you should think of when you see dry eye. So in a patient with dry eye, taking a meticulous history is very important, and thorough clinical examination, especially if you have access to a handheld slit lamp or a microscope examination examination under microscope is very important. Necessary investigations and prompt referral to your colleagues if you're not able to manage them is very important in managing these patients. Thank you.
Fantastic. Anthony.
Wonderful, Dr. Anthony. You covered the basic points of managing allergies and red eye. I think we have eaten into half of our Sunday. So I once again thank Dr. Mohan Rajan sir and Tnoa for this opportunity you have given Shankar Nethralaya, and thank all the speakers who made this a wonderful morning. Thank you, sir.
Thank you, Kavita, for the very nice update. I think it's been really a fantastic eye-opener. From A to Z of pediatric ophthalmology, we have learned everything. It's been a fantastic learning experience. I'm sure for the delegates who are watching on the YouTube and the Facebook also, it has been a very good learning experience. Is Madhavan, Tnoa secretary, online here? No. Then I request Dr. Jayanthan, the coordinator for this webinar, to give the vote of thanks.
Yes, sir. First of all, I would like to thank our president for making Tnoa shining and smiling always. It's a wonderful things that right from the last month. First, every session has been full, and we have crossed 1,000 viewers every time when we have a session. And next, I would like to thank Dr. Kavita ma'am, who has been coordinating with me for this wonderful session, and the entire panel of Shankar Nethralaya, who gave an excellent session speech today, and of course all the other speakers also. Finally, I would like to thank Xavier for powering this session, and the Numeratech for having the technical support. It was a really wonderful session. Hope it was useful for everyone. Looking forward for more such meetings in the future. Thank you so much, sir.
Thank you so much. So stay tuned for the next session on TNOA, which is going to be on November 6th, which is going to be the Walk the Talk with Dr. R.D. Ravindran of Aravind Eye Care System. And all the speakers and the panelists will receive a citation from the TNOA very soon. Thank you very much.
Thank you, sir.
Thank you.
Bye, everyone.
Thank you.
Bye, everyone.
Thank you. Thank you.
Thank you, sir. TSS, sir. Thank you.
Bye.
Happy Diwali.
How do you sit through strabismus, sir? I want to ask you that.
Pardon?
I was going to ask Dr. Mohan Rajan, how do you sit through strabismus?
He has to that post.
Yeah, I know. Thank you, sir. Good to see you.